For Medway being held here on Thursday the 1st of September 2022. First item on the agenda is apologies for absence, and apologies for absence have been received from the following board members: Councillors Martin Potter, Stuart Tranter and Gary Etheridge. In addition, we have Paul Bentley, the ICB representative, Becca Brad. You're representing, right, thank you, I understand now. Becca Brad, the Chief People's Officer, NH Kent and Medway substituted, thank you. And Donna Marriott, Assistant Director, Child Social Care, Medway Council. Thank you. With respect to invited attendees, we have received apologies for absence from Helen Gretorix, Kent and Medway NHS and Social Care Partnership Trust, and from Caroline Rickard, the Local Medical Committee. Item 2 is a record of the meeting. Is the record of the meeting held on the 16th of June 2022 correct, please?
Agreed.
Agreed, thank you. There are no urgent matters as outlined at item 3. And agenda item 4, declarations of disclosable pecuniary interests and other significant interests. Are there any declarations of disclosable pecuniary interest, please? None, thank you. Are there any other significant interests? Thank you. And finally, are there any other interests that anybody wishes to declare? Thank you. Now on to the main business of the meeting. As usual, may I ask those introducing reports to keep their introductions to a brief introduction, please. In relation to agenda item 12, the General Practice Development Plan, our health partners can only attend the meeting between 4:30 and 5:30. Upon their arrival and at the end of the item being discussed, I propose we invite them to present to the board. Similarly, our partners from Kent Police and Her Majesty's Prison and Probation Service are arriving at 4:30, and I propose they follow with agenda item 13, Violence Against Women and Girls, and HMPPS Reducing Reoffending Plan 2022-25. Is that agreed? Agreed. Thank you. Right. Item 5 on the agenda, the COVID-19 local outbreak management plan briefing, to be found on pages 15 to 30, agenda item 5, and I'm happy to pass this across to James Williams, our Director of Public Health, to say a few words by way of introduction, please. Thank you.
Thank you, Chair and members. And clearly when the paper was put to print, things have moved on a little bit further, as we might imagine, and in particular I just want to bring the board's attention to the reduction in the overall COVID alert state from level 3 to level 2, and basically what does that mean? So it means level 3, that the COVID virus is in general circulation within the UK, and clearly when they look at the methodology they determine whether it being in that position impacts on the way in which the system can work, and in particular the healthcare system. Reducing it down to level 2 is an acknowledgement that there is still COVID out there, but the rate is declining, and actually the impact on the health and care system is low, and the transmission rate is declining or in fact stable. And by reference to that, I just want to give you some latest updated figures. So obviously the England rate at the moment is 43.6 per 100,000. Within Medway, our infection rate is 31.9 per 100,000, and by proxy, the Kent rate is 47.5 and South East is 46.3. So as you can see, within Medway, the actual rate of infections, whilst it is still there, we still need to be cautious and make sure that we do all the things that we can do with the living with COVID guidance, but there is a recognition that the rate of transmission at this time is low. The levels can go up as well as down, so we're always clearly ready to respond should we so need to. It sets out in the paper the work that we've been doing to maintain our local outbreak management plan. And of course, we still retain our Health Protection Board. That's a joint board between Kent, Medway and other agencies, including the UK Health Security Agency, our communications colleagues from our NHS system. That's chaired jointly by myself, as Director of Public Health for Medway, and the Director of Public Health for Kent, Unjan Ghosh. The final point really, Chair, if I might, is just to reflect on some of the changes to the testing regime. We'll all be aware that we retained, albeit from April this year, that with the Living with COVID guidance, we ceased to do community-based testing, but we did retain a functionality to do asymptomatic testing. That's using lateral flow devices in particular settings, and they included some NHS facilities, care homes, prisons, place of detention, children's care homes. What occurred last week was that central government have put out a direction to say that testing regime, and that's just lateral flow tests. It doesn't include pillar one testing, so that's tests where people will get a sample and that get processed for a lab. These are just the basic devices that are used to asymptomatically find COVID infection. So that programme, i.e. the asymptomatic testing in high-risk settings, has now been paused, and I reaffirm being paused. It hasn't been councilled with a view to recalibrate and to look at where we then go through the autumn period and into winter, and that can be restarted. We still retain the functionality, should there be an outbreak or an issue or an incident, to go in and to do containment work. With that, Chair, I'll close my introduction, open up for any comments.
Thank you very much, James. Any member, please?
Can I simply congratulate those involved in the effort now that's going into the tackling of long COVID, because I think that long COVID, as its name implies, it seems to me that COVID kind of finds you out, and if you have a lot of other symptoms with that, you know, you really are going to get it in the neck. And I think the fact that we've got this group now that's working on long COVID, I think is really encouraging, and I'll be very interested at some date to see how you're getting on, perhaps, our next meeting.
Thank you, Howard. Did you want to respond, or? Right, Adrian, followed by Vince, please.
Thank you, David, and thank you, James, for your report. I think it is important that we do keep our guard up and maintain that capability for testing. If there's anything to be learned over the last couple of years, that this thing is totally unpredictable. We never know, there may be another variant come out of the woodwork. But like Councillor Doe, I was quite interested in the long COVID article, because having thought myself that I've got away with this, a few weeks ago I managed to get the damn thing. Fortunately, being fully vaccinated, and I think reasonably healthy, the actual COVID was no worse than having flu. So I just dosed myself up with day and night nurse and a occasional bit of self-medication with hot toddy, and I was perfectly fine. But what I did find, once I tested negative, I have never felt so tired for years. It was ridiculous. I felt like, as in a past life where I had to work more than 24 hours round the clock without any break, I was as tired as that, and you know, it was embarrassing how tired. You know, I had to go and have a lie down every once in a while, which is not me. I'm one of those awful people who bounce out of bed in the morning and full of vim and vigour. Hateful, I know, but that would normally, and it's not me even up to now. So there is, I think, something that needs to be looked at, and there's so much anecdotal evidence talking to relatives and acquaintances who are still suffering from having COVID 18 months, 2 years ago. So I think there is a real issue here. I'm just hoping this tiredness will wear itself off, but you know, it does make me wonder if we are on the cusp of having a significant long-term health issue with this, and I think it's important that we do try and investigate and try and keep on top of it.
You're right.
Thank you, Chair, and thanks, Councillor Gilvin, for highlighting, obviously, the unfortunate consequences of COVID infection. And clearly the work is being done in relation to the long COVID piece, and that will be a longer term endeavour. You're quite right to identify that. The other point just to note, and hopefully it does come through in the paper, is that we are into that next phase in terms of the vaccination programme. You quite rightly highlighted the benefits of being vaccinated, and of course I'm pretty sure colleagues in this room, we all might be of a certain age, will have received notification to come forward from the 5th of September. The autumn programme starts. Hopefully we'll get good uptake and an ongoing uptake, and we're not just talking here about the additional booster that's starting this autumn, but clearly anyone that hasn't been vaccinated yet, that's still an evergreen offer. You can come forward now, you'll be vaccinated. And also just calling to light the flu programmes. The flu vaccination clearly will start again. Our primary care teams and other colleagues are looking to make sure that we get as much coverage as we can. So COVID vaccination really important, as is flu, but the points that you make about surveillance and looking out for people, and in particular the services there, if anyone is suffering from the challenges that you've described, then clearly it's an engagement with your health professional and they will make the appropriate referral, and of course you can self-refer into the long COVID service.
Thank you very much, and thank you, James, and to the whole team and the whole system for how Medway continues to deal with this, tackle this. As you rightfully say, COVID is not gone away, contrary to popular belief. And I'm really pleased you mentioned the fact, and I'd reiterate this for anybody watching on or for anybody subsequently looking at this on social media. Medway has still got roughly 10% less at all three trigger points at first, second and booster compared to the national numbers. So we have good numbers, we could have better numbers. And I would encourage people, if they know that person who's ummed and ahed about getting a vaccine, tell them it's there, it's readily available, it doesn't cost anything. That's always important because, again, we know there's been some scams and all the rest of it, which is disgraceful and disgusting. So we need to continue to get those messages out there because, as Adrian Goldwyn rightfully says, actually, people are less likely to be seriously ill if they have those vaccinations. One of the other points I wanted, and like others, long COVID I think now becomes at least as much of a conversation. We've had conversations elsewhere about COVID sitting on the council's risk register, so I'm not going to rehearse those lines today, but people know my view and others' view on this, and I know we have a different view on that, and that's fine. I know I'm right, you know you're right, that's fine. Long COVID, I do fear, not just for long COVID in the physical sense. As Adrian says, I've heard many other people have had similar situations, sometimes for a week, sometimes for now over a year, and those symptoms aren't necessarily going away. It's about managing those processes. I said this at the last meeting, it's hugely regrettable nobody from KMPT is here, because actually one of the issues, and you could write a 100-page report on this, I suspect. All of the psychological and mental health impacts of the last 3 years are huge. And actually, that's the bit which I think I just need to feel a bit more confident in. If somebody is struggling with their mental health capacity, if somebody lost someone and wasn't able to go to a funeral and actually didn't go through that bereavement process, back in 2019, our mental health provision, like the rest of the country, probably wasn't at the place it needed to be, because actually we're getting better as a society at recognising issues, saying actually these are the things we need to do, whether it's talking therapies or all of the other great things that are in place now. But actually we've now added a shed load of pressure, and I'm not sure at this stage. We've got a great report, the Appendix A on long COVID for physical matters. There is mention of obviously of the non-physical impact, but actually that's where I'd like to know a lot more, and it's regrettable, like I say, that the key organisation that would lead on that work for Medway is not here today. That's regrettable. So I guess as and when we receive the next one of these reports, I would hope that either they'll be here or they can give their view on to what's working well, what needs to improve from the kind of mental as well as physical health. Thank you.
Yes, please do.
I just wanted to give you some assurance from a children's perspective. Can you hear me? That so I work for NHS Kent and Medway, and very closely with the Children's Commissioning team. We really recognise that bereavement support, especially for children who've lost parents through the COVID pandemic, was really having a big impact on their emotional well-being. And we have commissioned service that is hosted by one of the Kent Community Health Services, but is available to children and young people across Kent and Medway. So I wanted to give you some assurance about that.
Any other member, please? Well, thank you for your contribution. Thank you for your Hello? Thank you for your contributions. I'm going to hand back to James in a moment, but just one observation that at long last it does appear that things may be easing with regard to controls, particularly at border crossings. And I understand that France has lifted its restrictions entirely now, although it was only a few months ago that I travelled to France, and I couldn't help but feel that there was no real, in their view, in my view, they weren't really taking things in a serious matter, because having gone to France armed with my printed copies of the certificates to show that I'd had 3 vaccinations together with my wife and all the colleagues that I was with. We came off the coach in Folkestone, because you border control this side of the border, and they weren't at all interested to see any copies of vaccination certificates, check on mobile phones, nothing. All they wanted to do was check our passports, put the customary stamp that I haven't had in my passport from France for I don't know how many years, and we were through. There was no control whatsoever. And I thought, well, if that is just happening to us, it was everybody in the whole coach just went through with no control whatsoever. Even if they picked 10%, could have said, well, they're doing something, but there was nothing at all. But anyway, we are where we are, and I'd like to say well done, James, to you and the team for what you have achieved and continue to achieve in keeping us all in check and keeping us health and safety. I'll hand back to you now. Thank you, James.
Thank you, Chairman, and for the words, which it's a system-wide effort, as you've heard from Sue. The team is all of us working collaboratively together, and that, I think, has been the strength, or one of the key strengths that has given us, in Medway at least, but across Kent and Medway, the recovery that we're now seeing. Just, again, my final point, I think, around the COVID issue is that we have come quite a long way. And some of the issues that we flagged and that we identified locally, of course, the public inquiry has now opened and it's hearing evidence, so there should be learning that will come from that process that we can use to improve and adapt our local plans. And I think just the final point that was referenced there around the mental well-being issue, I think everyone would accept, all of us that have been through the last couple of years, that it has been challenging. So the points that you make are really, really important, Councillor Maple, in terms of how do we actually respond and how do we build resilience into our communities for the next thing that will come down the line. I think that's quite an important thing for us to note. Just by passing, remember, mental well-being is one of the system priorities for the Kent and Medway Integrated Care Board. So regardless of whether it's coming from COVID or other factors, there is a clear commitment there that something will be done to support people in their time of need. And I'll close on that, Chair. Thank you.
In that case, Chairman, can I move that the report be received, and with appreciation of the efforts that have been made so far to combat COVID in Medway, and we look forward to a further report on update, particularly in relation to long COVID.
Thank you, Vice Chairman. Recommendations are on page 22. Are we agreed, please? Thank you. The next item on the agenda is item number 6, which is the Pharmaceutical Needs Assessment 2022 to 2025. On this particular report, I'm going to hand to David Whiting, Dr. David Whiting, the Deputy Director of Public Health, and he'll introduce this item. David, please. Thank you.
Great, thank you very much. So it's a statutory duty for local authorities to prepare a pharmaceutical needs assessment every 3 years. Our last one was produced in March 2018, so we should have had a new one by now. But the government changed the timeline for updating refreshing pharmaceutical needs assessment because of COVID, and one is now due by the 1st of October this year. The pharmaceutical needs assessment describes the needs for pharmaceutical services in an area and is used by NHS England to control market entry. So, for example, if a pharmacist wants to open up a service, they must apply to NHS England to be included on the relevant pharmaceutical list by proving that they're able to meet a pharmaceutical need as set out in the pharmaceutical needs assessment. The pharmaceutical needs assessment has a defined scope. So, for example, it needs to show the current services that are available and their opening hours, and to identify gaps. But there are other aspects that related to pharmacies that are not required to be part of the P&A. In developing our P&A, we sought the views of members of the public and pharmacists in Medway, and we received just over 400 responses, which is actually quite a good response rate. These responses were considered in the development of our pharmaceutical needs assessment. The draft P&A then came to the Health and Wellbeing Board in April, before it went out for a 60-day consultation. This consultation received a smaller number of responses, but this is quite normal, and the response rate was similar to what is seen in other local authority areas. The P&A has also been to Health and Adult Social Care Overview and Scrutiny Committee for scrutiny, and has now come back here to the Health and Wellbeing Board for final sign-off before publication. I'll just highlight a few key findings from the P&A. The current provision of standard 40-hour pharmacies should be maintained, especially in rural and outlying areas. Loss of any of our 100-hour pharmacies could cause significant gaps in access to both essential pharmaceutical services and locally commissioned services that respond to particular population health needs. There are proposed future housing developments across Medway, which will mean that these areas will need to be reviewed on a regular basis to identify if any significant increases in pharmaceutical need occur. I'll end my summary here, and I'm happy to take any questions.
Thank you, David. David, I'll begin by saying I was particularly interested to note the comments from the Overview and Scrutiny Committee on the 16th of August, which I think are very, very good. They've obviously done some research themselves on the very points that have been raised. But unless I've missed something in the report, the one thing I couldn't find mention of was the surgeries that actually have a pharmacy attached to them, which means that somebody can literally see a doctor, come out with a prescription, and then pop next door for the prescription. Is that included in here, or was I right that it is not included? Oh, okay, because I went through a couple of times when I picked it up and I couldn't find it. But no, if you say it's in there, that's fine with me. Right, any other member, please? Vince, please.
Thank you. And I would agree with, I think, the comment made around actually the level of consultation response. That's a good place to be. I think we should recognise that. And I'd also want to recognise, actually, James Williams rightfully said that the whole COVID approach over the last 2.5 years has been a team effort. The role that pharmacies have played throughout that 2.5 years has been outstanding, and I certainly recognise that. I would say that Palmer's in Palmerston Road is particularly good, but all the other pharmacies across Medway are equally good as well, I'm sure. I wonder just around, obviously this plan is in place for the next, well, the assessment is in place for the next 3 years. I wonder whether there is something from the council's perspective when it comes to the issue of planning. And again, this is not my area of expertise particularly, but whether some recognition needs to be within our planning process to say, actually, if you're looking to build 100 homes here, this is going to trigger a conversation or do something somewhere. It may be that that happens already, so if it does, feel free to tell me that. But particularly with where we have some weaknesses, where the provision is less strong, actually that's probably where the most houses are likely to go. So it just adds on that pressure. So I think with that recognition, as you rightfully said, David, I think the questions asked by overview and scrutiny, very pertinent, very relevant, and I think the responses are helpful accordingly. So on that basis, I'll be happy to support this. But I'd just, again, maybe not for now, but outside of the meeting perhaps, an understanding as to the relationship between this document and the council's planning team and system.
Thank you, Vince. Just one more item for me. I found the reference to GPs. Isn't it strange where it's right in front of you, you miss it? So my apologies, David. I've now found it. But the comments that were being made relative to the smaller services available, and Vince has highlighted, obviously, the pharmacy in. I don't think he lives quite next door to it, but he doesn't have any problem finding a pharmacy. But I think this is generally the case across Medway. I think we're well placed. But I seem to recall a few years ago when we really started to kick off with the pharmaceutical needs assessment, that particular mention was made of St Peter's Village, which is on the other side of the River Medway and into KCC patch, versus Cuxton, the village of Cuxton. And St Peter's Village were putting forward that they should have a pharmacy in their village to complement the services available to their community. But when it was pointed out that there was one just across the river, accessible via a bridge, and they could access Cuxton, the response was, well, that's okay, but we want to look after the people of their own particular patch in Kent, to which we responded, well, that's fine, but it's either one or the other. Nobody is going to keep two pharmacies open. You either have St Peter's Village or Cuxton. And the people of Cuxton have got to say equally, if you want the pharmaceutical facilities, you come to Cuxton. And I think at the end of the day, the last time, or both sides were allowed to keep their pharmacies, or St Peter's Village developed. Do you know what actually happened with that particular case? Because I'd hate to see a service taken away from the people of Medway. Please.
Right, so it's a sort of fairly technical issue in terms of, the pharmacy in question within Cuxton was a dispensing practice, and there is a rule that you can't have a pharmacy within 1.6 kilometres, within 1 mile, as the crow flies, of a dispensing practice. So we were asked for our opinion about this new new pharmacy that wanted to open in Peters Village, and that happened to be within 1.6 kilometres, but there was a big river in the way. So even though it's 1.6 kilometres as the crow flies, for residents of the Cuxton area to get there, it would have been quite a long journey. So that was our response to NHS England, and that practice is still dispensing within Cuxton, so I'm assuming that they listen to what we put forward.
Thank you, David, and well done on that one. I think it was important that such a service was retained for the people of Medway and in particular Cuxton Village. But thank you. There being no other member, I'll pass to the Vice Chairman, please. Thank you. Are we agreed? Thank you. That's it. Moving now on to item 7, Joint Special Educational Needs and Disabilities, the SEND programme, pages 173 to 210. Wendy Vincent, the Head of Integrated Disability Medway Council, will introduce this item, please.
Thank you. Thank you, Councillor
Thank you very much, Wendy.
I have with me my colleague Sue Gibbons, who's the Designated Clinical Officer as well. So this is a refreshed joint SEND strategy to replace the current SEND strategy, which has run from 2019 and has come to the end of its life. The current what we're doing in the strategy is setting out our vision and guiding principles and the key ambitions for the next 3 years to be delivered within a sustainable system. Currently the strategy is in draft and there's a live consultation going ahead at the moment, which finishes on the 23rd of September. And the strategy will be updated and finalised following that consultation. This strategy has been co-produced with young people and families. They were very keen to have a concise, colourful, clear strategy that meant something to them. And they came up with the 5 ambitions that are clearly described in the strategy around inclusion, early intervention, working together with children and families to plan services, having the right access to the right support in the right place at the right time. And they were particularly keen for the emerging recognition of the impact COVID pandemic has had on children with SEND. And Sue's already told you a little bit about some of the work that's starting to happen around that. The strategy links very clearly with the child-friendly Medway, child-friendly Medway and the People Strategy, and also the Safety Valve Intervention Programme. So a full action plan will be developed underneath this strategy. I'm currently starting to work on that. So under each ambition, there'll be some firm action and time-limited action plans, which will be overseen by the SEND Partnership Board and some cabinets. And Sue and I are very happy to take any comments or questions when we ask you for comments on the strategy.
Thank you very much for the report. Particularly well presented. And my personal view is that you've actually highlighted and ticked so many boxes that are needed for the children and young people of Medway, in particular 1.3 child-friendly Medway and children and young people plan, and also 2.4 highest expectations for children and young people with SEND in Medway to deliver the vision and achieve these priorities. Our principles for all our services across partners and agency is to, etc., etc. I believe those 2 particular sections tick so many boxes that congratulations to would be my take on this. Any member, please. Vince, please.
Thank you very much. This is a good starting point, and I think it's a good conversation to be had. And it's one of those issues you reflect after you've been around a while, which I sadly have these days. And I think the recognition in the system, so not the council, not the health system, not education, the system as a whole, of going from treating kids with special educational needs as a kind of homogenous lump of several thousand young people to actually recognising everyone is individual, everyone needs the the support that they deserve. And when I talk about they, it's not just them, often it's their families as well. They're a key element to this. And I think we're at a bit of a challenge here because you've got, as I said earlier on, some bits of the system were not brilliant. And that's not a Medway problem, that's a national problem. So CAMS, in the 15 years I've been a councillor, has never been good enough. And that's not just here, that's everywhere. So I think that if you start from the point of recognising something like that and go, so we know there's a problem, before you throw on top and it's really, I really welcome Ambition 5, actually. That is so important, and it goes back to some of the stuff Sue was saying a couple of agenda items ago. And I don't expect you to have all the answers today, but I guess it's around saying, so that ambition is great, but what does that mean when schools are saying, actually, we haven't got enough money to do what we were doing last year because the gas and electric bill is going to be ridiculous. So then saying, actually, can you find some funding for some educational psychology or whatever it might be, different for different kids. And of course, that's just one, effectively, that's just one strand of special educational needs and disabilities. There's a load of other stuff you've got very helpfully in here, the kind of breakdown, and where Medway is slightly, only sometimes slightly different, sometimes slightly above, below the national stats. So I think this is it's a good starting place, but again, I think it's that document underneath it, it's the work underneath it to say, actually, how do we do this? We know there are conversations that have happened in this room at full council around things like high needs block. We don't need to rehearse those arguments today. I think there's a pretty strong consensus around 55 councillors, professional officers and everything else. We are where we are with that, so we can't change that from the conversation today, but it's worth noting this report is with that backdrop. And I guess really, I guess the one question I would have today really is if we are going to meet these ambitions, and I think we would all want to, why wouldn't we? It's around resources, actually, and that's a collective pressure, because actually some of the stuff we talked about again on the first agenda item around the post-COVID world that we're living in, and then Department for Education will say, actually, keeping children safe in education this year, there's a real strong focus on SEND, as well as domestic abuse and child-on-child abuse, and I'm sure most people saw the horrific stuff on the news yesterday. So all of that in the mix. So this is good. It's a good starting point. I'd urge people, if they're watching on, to take part in the consultation. Nobody knows families better than families, and I'd want to hear from them. And it's great that they've been part of the co-production of where we've got to so far. But I guess the reassurance around we won't be able to do everything because we haven't got the resources. You know, that is a challenge, but particularly for, again, without falling into all of the political cliches, children only get one opportunity. You are only a child once. You will only go through the school system and the wider support system. And David's right to say things like child-friendly Medway are helpful, but actually schools may well be in a position where they're going, well, we want to do this, but we haven't got the resources. And it's not just schools. So I agree this is a great document, but I am concerned not about the passion and desire and the professional expertise and the co-working we have in Medway. All of that is almost a given, and we should be grateful for that, rightfully. But it's just where we are in the current climate, which is out the hands of everyone around this table. So, there. And I don't expect, Wendy, you may have an answer, but if you don't, that's fine too, frankly.
I think you've helpfully summarised some of the challenges that we do have. I think for me, SEND has never been higher has never had a higher profile. We've just had a new green paper out, which is setting out responsibilities for us, strategic leaders. There's a new SEND inspection framework about to be launched, again looking at the importance of everybody working together and working effectively. And I think for us, as lead professionals, really, there's a lot of research and things that's happening about what actually works, and some of that isn't expensive. So it is about just making sure that we know what the best practice is, what works, what has the best impacts for children. And for me, it's about, whatever we do and however we spend that money, we make sure that that is impacting in the correct way on the kids.
Yeah, I was going to agree with Wendy, and thank you for raising that, because I agree. But the Green Paper hopefully will give us some stance, but not all, but the effective working together, which we have to build on and sustain that in the future, is really important. One of the things that obviously the recent change around how the Integrated Care Board is going to be working hopefully will give us some support in making sure that SEND remains a real priority, both in Medway and across Kent. But from a resources perspective, I think working together more smartly is the way we can achieve great things. So that's what we aim to do as well.
I really welcome those responses, and again, I apologise. I've obviously had my Weetabix this morning, because the last thing I'd say is, of course, that there are, again, from a political perspective, there are some solutions which there's cross-party support for, but they don't happen overnight. So I don't think there's a single councillor that wouldn't want the Cornwallis provision, or whatever we're calling it now, to be in place, frankly, yesterday. But it's not, and it's not likely to be there for at least some of the lifespan of this report. So I recognise as well that actually there may be great ideas and great solutions that just, because of practical reasons, just can't have the impact that we would all want them to have in the lifespan of this report.
I think, through you, Chair.
Yes, please.
I think this is a highly complex area, but the good thing about this area is you've talked about co-production. I'm always very, very pleased that it's a partnership solution, that parents and their children are the #1 drivers for everything we do. And I take some comfort from this strategy that you'll see those threads running through it. Now, you're absolutely right. It is an expensive area, has always been expensive. We have great ambitions for our children in Medway, and there's a certain level of frustration that goes with those expectations. But I see the ethos that's been woven through this strategy as beginning to be the lever to move those practical solutions on. And partners have certainly signed up to this. Our health colleagues, our DFE colleagues. I don't think there's anyone that isn't up with the play. But it doesn't take away what I think you're getting at is that frustration of jam tomorrow.
Thank you, Leanne. Any other member wish to speak? No? Thank you. Can I pass across to you, Mr. Vice Chairman, please? Is that agreed? Agreed. Thank you very much. We now move on to item 8, State of the Health and Social Care Workforce following COVID-19, to be found on pages 211 to 216. Becca Brad, you're going to present this, I believe. Thank you.
Thank you, Chair. So I think firstly, just to say it's been an extraordinarily challenging time for our health and care workforce over the last 2.5 years, supporting a pandemic. And I think what we would want to recognise first of all that what those colleagues have achieved has been unprecedented and should be celebrated given the circumstances that colleagues have worked through. The workforce challenges that we have in Medway and nationally were there pre-pandemic, and this paper sets out how that position has moved. We've seen some improvement within health over the last 2.5 years in terms of growth of key workforce in clinical and professional workforce. But we also recognise that there are some areas that we still continue to need to work on, including primary care, although we will hear about the primary care development plan a little bit later on in terms of that. Wellbeing is one of the top priorities for health and care colleagues, and all of our organisations take that very seriously, and we've been working together to look at what we can do to continue to support the health and wellbeing of colleagues. A range of offers are in place, and we've shared a range of those offers within the paper. So we're asking, I don't know if Jackie wants to add anything particularly on the care workforce, but we're asking the board to note the progress that we've made within the pandemic and the recognition that there's still some work to do. Jackie, I don't know if you want to add anything.
Did you want to add anything at this point? Thank
Yes, Chairman. I think that this has obviously been a very, very difficult time for the health service, and I think we really do recognise that, because when you're in contact, obviously, with patients every day, you're much more likely to get COVID than anybody else. And I think battling their way through that has been very impressive, actually. So I think we should perhaps recognise the fact that quite a lot of people they've been working not in their own jobs but other people's jobs during this period, and it's been extremely stressful. I'm pleased that actually it does seem to be getting back to normal now, but it will be a process. And whilst I don't want to encroach on the next item, which is about digital inclusion, I do think that it has actually caused the health service, as it has Medway Council, to actually look at the way it provides its services to see if they are being provided in the most effective way, bearing in mind the digital revolution that's taken place. So I welcome that and ask the board to note the update.
Thank you. Vince, please.
Yeah, thank you very much. And thank you, Becca, for the paper on with Jackie. There can be no one in this sector when they trained, whether that was 3 years ago, 33 years ago, or anything else in between, who could have genuinely you couldn't have been prepared for the last 2.5 years. It was impossible from no other reason, from a kind of human perspective. People who are on a 0 hours contract, on the minimum wage, having to sit there with a laptop or an iPad as someone's relative is dying, that just saying that sentence alone makes you realise that actually, and there will be, out of that 1,100 number in the care workforce, let alone the wider workforce and the wider health community. I mean, I've spoken here before about PTSD, and I don't think that's explicitly mentioned in here, but there are certainly in the wellbeing section references to trying to help people as best as we can. And look, we can say thank you every day of the week, but actually that doesn't cut it, frankly. It is really disappointing to see that Medway has 30% of workers in that sector, in the care workforce specifically, not the wider sector for clarity, who are on a 0 hours contract, which is, depressing, particularly when you say actually that's one of the highest in our region. And I wonder if we know why that is. Do we have an understanding from providers? Is that around flexibility? Is that around just cost? Why are we doing that and others aren't? Because clearly others aren't, otherwise they would be in the upper quartile and we wouldn't. So there's something around that specifically. I do, and I know Teresa Murray has spoken about this elsewhere, and I know some parts of the system have done a little bit of this, but at some point, whether there is that kind of collective Medway recognition of just what we've all been through. And there'll never be a right time to do that, because James Williams rightfully said right at the start, COVID is still here, that's true. But whether those sorts of things can help as part of that process. And I guess the other question I would have, and this is around the whole sector, so all bits of it. Obviously, lots of people haven't left, actually. And I'd like to understand, in the nicest possible way, why haven't you left after everything you've been through? Almost like a non-exit interview in that sense. And we've had those conversations about other bits of the public sector recently. So I wonder if some of that is happening, and just to get an understanding as to why people are staying. Because actually, I would understand entirely if every single person of that workforce was to say, I can't do this anymore. So look, there's a lot there. I appreciate that. Some of it is out of the hands of people in this room, but you may well have some answers. But yeah, in particular, the most depressing statistic in this is that being in the upper quartile. I wouldn't want everybody else to have 30% of workers on 0 hours contracts, but if they were, at least it'd be equality of misery. Medway's getting a raw deal. Medway's women and men who are there caring after our loved ones are getting a bad deal. And I'd like to understand what more we can do to try and learn from other places to get these employers to at least think a bit more and try and be a bit better. Thank you.
Thank you, Councillor Maypole, and Sue's arrived just in time, so she might be able to add to this as well. I think there's a raft of reasons. So the 0 hour contracts is around flexibility, particularly for working parents. We do see pressures in the holidays, the school holidays. So in the paper it talks about the number of people waiting for care, and I've mentioned in that doesn't include the number of people in Medway Hospital at the moment that are also waiting to be discharged for care. People take those on because it means that they don't have to work in the school holidays, but then can go back in, when children are back in school and around care and responsibilities. It is high, and I don't know that we could definitely give a reason, but I think it's something that we need to consider and look into. With regard to the recognition element, I think it was a year ago, but it might have been longer, I can't remember. James, through the Better Care Medway award ceremony, we actually did do a piece where we invited our home care providers, and we asked for nominations actually from people that they supported. So it wasn't from ourselves, it was from the people that they cared for, and did a meal and a presentation. That went down really, really well. It was only for a few providers, not everybody came, but really appreciated. And we'd put in place something around we'd got funding externally to give them free parking in Medway, so parking permits. So although from a salary perspective, and it talks in the, people being on minimum wage, things like that do help, but we have got to do something about the salaries that they are paid. If we talk about why are people leaving and why are people staying, from those awards, you could really feel why people did the job. They are doing it for a reason. They want to care. They want to be supporting people in Medway, and they will do that through thick and thin. There are other people that really want to do the job, but actually they've had enough. You talked earlier on about PTSD, and some of the feedback we get is if you've got somebody that's going out to see 9 clients a day and they are putting on their PPE off, out, into another house, same, re-stripping everything and doing that, and in care homes seeing some really difficult situations, some of the people just said, you know what, I can't do this anymore, I've had enough. And then there is an element of it which is where some people do it because it's the job, and I think that's the fewer people, but we have to consider that, and that's why some people haven't stayed as well. I think the care reforms and the work that we're doing around that at the moment about what does a fair cost of care look like and how do we ensure that people the providers are being paid appropriately is fundamental to us improving the care market. But what we've got to do is we've got to make sure that the providers pass on some of those increases to those hourly rates. You know, people are being paid £9.50 an hour to do this job, and you know, working their socks off to do that. And we're obviously seeing pressures because of fuel increases, you know, cost of living increases and so on and so forth. So the care reform work that nationally is being done, but we're doing in Medway is going to be really significant about how do we improve. And I think that answers. I don't know, Sue, if you wanted to touch on the 0 hours, or are you happy with? Okay.
No, you answered perfectly.
Before I pass across to the... did you want to come back, Becca? Sorry.
Just to one point, just to reiterate around from the health perspective, the dedication and passion of our staff. So I think we did have very low turnover, I think, in Medway and nationally, because colleagues were really dedicated and want to support our patients and our citizens. I think what we have a concern with, not just Medway but nationally, is how long that turnover will stay at those levels. So I think there is something that we're all working on as our organisations and as a system to make sure that recognition's there, to continue to support the health and well-being of colleagues when we know that we're going to obviously have a difficult winter.
Before I pass across to the Vice Chairman, just a couple of points I'd like to add, please. As the presentation was going on and people asking questions, I just cast my mind back to the very first managerial role that I had within in industry. And I always remember one of the first things that was ever said to me, and that was about working with people. Never take people for granted. Never take your staff for granted. You need to work with your staff, you need to understand your staff, and you need to be able to get the best out of your staff. When I think what's happened since the pandemic started to ease off, is that we have lost so many people from the care sector. It's unbelievable. And if this was any other organisation, whether it be a local authority or whether it be the health service in particular, I believe, needs to look very closely at itself. And I think the health service needs to put up a big mirror on the wall, and each and every one of those responsible for looking after the people and the carers need to take a long, hard look at themselves and then begin to think, what have we collectively, what have we created? And the fact is, we have a mess. We've got a big mess that's got to be cleared up. And everybody is looking at the local authority as though we've got the resources and the ability and the finances to be able to sort all of these problems out. Well, the fact is that as an upper tier authority, Medway Council does not have the budget to sort out the whole of the problems associated with Medway and Swale, or indeed other parts of the country. Now, I'm speaking from a local authority point of view, and I know that I'm probably echoing the words that have been said by local authorities all over the country. What has been created is that we have all of these people that have been leaving the care sector. And why are they leaving the care sector? Everybody puts it down to the fact that, well, it's the 0 hours arrangements, it's the pandemic, they've been working long hours. Yes, we know all of that and we appreciate all of that. But sadly, as a local authority, our hands are tied. We can do no more. Unlike the National Health, when it comes to the end of the year, the local authority has to satisfy its budgetary requirements. We can't overspend like the NHS. The NHS overspends, well, that's no problem. The government will help us out, the government will bail us out, and that happens each and every year. But unfortunately, when it comes to a local authority, an upper tier authority such as Medway, that is never ever the case. We're not allowed to overspend, and if we do overspend, we could find ourselves having a special officer coming in from central government to sort us out. Now, we don't want to reach that situation, but quite frankly, we are being driven very slowly but surely down that route. And I'm not alone when I speak up for Medway Council, because as I say, this is happening right across the country. And please, the NHS have got to wake up to the fact that you have a part to play in this as well as us. We talk about partnerships, we talk about working together, but please, can we see some of that in action? Can we see some of that on the floor? Can we see some of that through people being encouraged back into the workplace and being recognised for the job that they do, and the fact that we need those people to look after those that really need the care packages, because we are falling over. So with that, my comments ended. I'm going to part. Oh, sorry, Vince. Make it a quick one, Vince, please.
I will do.
Because
it's always helpful when you've got another note on another page that you didn't look at. So this is definitely one for Jackie and possibly Sue, and possibly Becca, but I suspect not. Of course, one of the other things, as well as COVID, that has happened in the last few years is Brexit. So I just wanted to get a sense of feeling, particularly for the care workforce, but it may well be for the health workforce as well, as to whether that has done two things. Have people particularly, and I know anecdotally I've heard this, but I'd be appreciative if we can get some clarity, whether at the start of COVID, people who are not from the UK went back to where they originate from and are not coming back because they've chosen not to, and equally whether the workforce, again, predominantly in care, but not exclusively, is it more of a challenge now to fill some of the vacancies, because certainly over the last 25 years, I suspect, if not longer, a chunk of those vacancies have been filled from people from across Europe. Thank you.
I don't know the answer to that one, so I'm going to have to come back to you. I know that there was some pressure. Sue, do you know? Okay,
Yeah.
I will say that there are some challenges, not necessarily, I'll let Sue talk about the recruitment, but around some equipment because of Brexit. But I'll let Sue talk about the recruitment side.
Thank you. Just very briefly, yes, it did have an impact of about 20%. That decreased as we stabilised, and some local authorities, or no, some providers have gone through the route to have that exemption. It's quite a lengthy programme, so I think it's quite off-putting at the moment. I think the government then resisted because there was some misuse of that, but they're improving that to make it come forward. So I have hope that hopefully in the middle of winter we have a better system to be able to recruit internationally.
That's very helpful, thank you.
Chairman, if I may,
Chairman, please.
Before I move the motion, I'd just like to say that I think that one of the things that's really, and I'm very much with you, Chairman, on this, and then the other members have spoken, I think the problem we have here is one which is far greater than the rises in the cost of energy and so on. I think what we have is, whilst we locally appreciate what local people do, you know, in the way of social services, quite frankly, when you hear tales of people stacking shelves somewhere and they're earning more than people who are carers, then it seems to me that society generally isn't recognising financially the role that those people play. And those costs will have to be picked up somehow. Part of it will be, and I don't want to again stray over to the next item, part of it will be in telecare and telemedicine. But more than that, I think there's got to be a recognition that these people are, if you like, right in the front line of both medical and residential services. And we really can only limit that with digital, with digital help. But at the end of the day, those people will have a very large responsibility, and it isn't being paid for, frankly. And I think there's a total rethink is needed in this area. And if it doesn't happen, I mean, it will happen, but it'll only happen after the horse has bolted, unfortunately. And then, you know, all of us round this table will then be trying to put back the genie into the box when people have left the service. And I think that actually we're relying a lot on the goodwill of people in the care sector. That goodwill is not certainly being paid for as it should be paid for which councils or just the health service don't, I think, have that responsibility in the sense that they can only disperse the money that they have. And I think it's a very serious situation. It's something that, this is not political. I think neither Conservative nor Labour or in the Liberals have ever looked at this really deeply because they fear the answer. And I think that that has to come forward. It really does. Otherwise, these losses that we're suffering, these quiet folding of care units, brought into the private sector, this is actually going to hit us so hard that we'll get to a point where we say we just can't help you, because we don't have the resources. And in some cases, I suspect that may even be happening. Not perhaps in Medway, but certainly in some places. And, I do want to make the point that, I think all around this table, we sympathise a lot about that. We're very, very grateful to our to those in the service that make these sacrifices. But how long you're going to work on the basis, how long we can afford to work on the basis that they do this out of their goodwill, as it were, whilst being paid things that, for mundane jobs that really have no responsibility compared with this. And when care workers know that at any time the roof can fall on them because they've actually been looking at a number of cases. In one case, they perhaps didn't quite hit the spot, and everybody is after them because they take that case out of the parameters. They're not, don't worry about the other 10 or 12, 15, whatever you may be dealing with. That case, you didn't get it right. We're going to pillory you. And I think there's got to be an entire rethink of that process. And I know that David has been pressing for this, but I know this much, that it won't be a question of who's pressing for it. It'll be a question that those people won't be there, and you're going to have to buy them back in, which is going to be extremely difficult. So, I think there is a real challenge coming up on this. I'd like just to then move that the board note the update and express our appreciation to those in the care services that have helped us through this COVID crisis at really quite some cost to themselves.
Thank you, Vice Chairman. Is that agreed? Thank you very much. Thank you. Sorry about that, but as we explained at the beginning, we're playing this is a little bit of a juggling act this afternoon to make sure that we fit all the people in that need to be here this afternoon with us. So after consultation with Jade, our trusted officer, who I ought to say, welcome back, Jade, because I forgot about that, really. Jade's been out of the field for a little while, been on maternity leave, and she's now back with us, and we're very pleased to see her. So without any more to do, I'm going to get back onto the agenda. But the next item is the Medway Council Digital Inclusion Strategy Update, and this will come from Paul Boyd. Is that correct?
Thank you, Chair.
Thank you, Paul.
So at the Health and Wellbeing Board on the 10th of February, James Williams presented a paper on bridging the digital gap, improving health outcomes through digital innovation. So that paper provided a clear position statement on the range of issues such as digital connectivity, digital poverty and telecare. And a digital inclusion strategy was required to move Medway particularly towards bridging that gap. So this report asks that the Health and Wellbeing Board support the development of the digital inclusion strategy within the wider digital data and technology strategy, which has currently been drafted and will be going to Transformation Board on the 20th of September. It is felt that integrating the digital inclusion strategy within the wider DDAT, which is what we know it as within ICT circles, will ensure a coordinated approach and ensure that inclusion and accessibility issues become part of business as usual. So I'm reminded of the story of the school caretaker cleaning snow from the school before the students come in, and he clears snow off the steps because there's lots of children there waiting to get in, and there's one child in a wheelchair, so he doesn't do the ramp, he does the steps. But of course, if he'd done the ramp, everyone could get in. And that's the approach we want to take to our digital processes and our services online as we develop them going forward. You'll notice in the report that we've consciously used the term customer choice. So previously this might have been referred to as digital channel shift, but as a team we felt this had negative connotations as trying to force people to use online channels. That's not the case at all. We know there's a demand for residents to use online channels because there's no queuing, they're available 24/7. So we want to provide that customer choice for those customers that want to use the channels to use them, and then we expect that will reduce the demand, allowing us to focus resources on those residents that really need it. So at paragraph 2.6 of the report, it outlines within the DDAT strategy the specific areas focused on digital inclusion, and that's access and inclusion, helping customers that cannot or will not use the website, public access, and since the publication of the papers on the revised draft, that's now digital poverty and public access, broadband access and infrastructure in Medway, barriers to using digital services, assisted digital tools, self-help via the website, web chat and social media, assistance in person, and assistance over the phone. So it is recommended that the digital inclusion strategy be incorporated in the wider DDAT strategy that will be going to Transformation Board on the 20th of September. So I'd like to propose that I come back when the full strategy has been written and share it with a future Health and Wellbeing Board.
Thank you, Paul. Any member, please. Howard?
Well, can I first of all congratulate Paul and all the others across the services that have been involved in what I only described as a digital revolution. I think that I was speaking earlier about the fact that our resources are obviously stretched to breaking point. But one of the ways in which I do believe that there can be a much better resolution of these things is by clever use of digital access. And I think that what is so reassuring to me is that people are not being forced down that route. I think we've got to actually cater for those people, probably at the most vulnerable time of their life at the moment, who weren't brought up, or even in their youth, you know, tackling the challenges of digital inclusion, and therefore they're just frightened silly about it. And I think we can do quite a bit about that. You know, we can actually bring them along with things like telecare and so on. And by appreciating that many of them are actually using technology even though they don't realise they're doing it. But I think that it has vast rewards in it, I think, for healthcare and for social care. I think that telecare has come on so fast and is coming on even faster. And I can say that now I'm no longer a director of Kindy. And I think that getting the access to broadband is obviously very important, but that will come, I think, fairly soon. But I think to everyone. But I think the answer really is that it will enable us to stretch services like, for example, trying to get through to your doctor and so on, when you can actually do some of it by digital connection. But of course, there has to be the time when you can't use digital connection. And it's having that choice, really, and teaching people how to exercise that choice in a balanced and reasonable way, that I think that is the big challenge that faces digitalisation in every field, really. But the rewards are enormous, and I think we've got to strive for them.
Thank you very much. And Paul, thank you as always for your work on this. I'm lucky enough to sit on a cross-party group, which acronym is MUG. So we're all mugs, and that's
No comment.
It stands for member. There's more Conservatives on there. There's more Conservative mugs than Labour
pleased to
mugs.
hear that.
So, but that stands for member user group, and we are the kind of technological guinea pigs, perhaps sometimes. I don't know. So I'm lucky to have seen some of this work in action, and Paul would have heard me say this before, but for others who are not mugs. It's about the Venn diagram of where we are. So over here, we've got all the people who are going, my goodness, that Medway Council, you're miles behind. Why aren't you doing the same as Amazon? You've then got the bit in the middle who are comfortable using it. Sometimes might like to speak to a person, but actually we'll get on with it. And then there's a group over here, including by his own admission, one of the members of, not of my party, but one of the Conservative members who would absolutely be in that third bit of the Venn diagram, which is, I'm not even switching on my laptop, not even switching on my phone. No thanks. So I welcome this, and I guess from a health and wellbeing board perspective, it's about recognising that the council is an important player, but it's of course not the only player. So it's about understanding how this strategy will sit with the NHS strategy, MCH's strategy. I won't go around the whole room. Other people are available as well. And just understanding that for a Medway resident, you know, if they are receiving care, can we get to a point where they don't need 4 different apps? Which perhaps if they're trying to talk to their GP through a e-appointment, which for the avoidance of doubt, were always going to happen before COVID. I'm always strong to defend GPs. They've got a lot of things to get right, but that's one thing they were told to do. So it's about understanding for when you come back, Paul, with I'm sure what will be an outstanding strategy and part of that wider DDAT strategy. I'd want to see how it fits with the other parts of the health and wellbeing family that we have here in Medway, recognising that some of that will be county-wide, some of that will be regional, some of that will be national. That's a challenge as well. And I think that puts the local authority in a stronger place because it can be for Medway. There'll be other bits that can probably do that as well. And then, of course, it's how it sits alongside, you know, making sure that throughout all of this, the voice of the user, resident, customer, whatever language you want to use, is at the heart of that, making sure the systems work for them. I agree, finally, that getting rid of the phrase channel shift, it either makes me think of someone watching something different on telly or someone trying to jump over that bit of water between us and France.
Thank you. Did you want to come back on that one, Paul, please?
If I could, and having the DDAT strategy is the first time Medway has pulled together its ICT, digital, data into one strategy that allows us now to compare and integrate with what the NHS are doing, with what KCC are doing, and it also complies with what central government's doing, so it is the mechanism to join up all of those different strategies.
Thank you, David. Well, as a council, we've been on this digital transformation journey now for just over 6 years, and it's interesting that we've now dropped the digital bit of it. You know, it's not the digital transformation board, it's the transformation board. Digital is just the tool that enables us to do it. The most important thing is changing and looking at your working practices, your methodology, and the technical bits just help you on that journey. They're not the most important thing, and I think that sometimes gets lost when we talk about digital exclusion. I can assure you, I will use that awful expression, channel shift. The channel shift that we've enjoyed has been entirely voluntary. There are no means of accessing the council that have been switched off to force people down the digital route. The shift has entirely been voluntary, and the reason it's been voluntary is we've been able to, through Paul and all the other team members involved, and produce as good ways of doing things that people find them easier to use, and that's the right way of doing it. We're talking about now 85–90% of people's, in some services, connection with the council is done via digital means, and that's fantastic. And it's interesting, a lot of those, like the blue badge services, which are people which a lot of them are not the first people do think would have grabbed that sort of service, means of service they have. And I think one of the few benefits of the pandemic has been that it's actually made people realise that these means of communication are there. And I have to now keep my phone usually switched off because our church's WhatsApp group is constantly pinging throughout all hours of the day and indeed night, because our predominantly elderly congregation in the church I belong to have grabbed it with enthusiasm. You know, there's people in their 90s who are WhatsApping and the whole day, and I think it's really fantastic, because one of the things we've learned on the Health Wellbeing Board is that exclusion, not digital exclusion, but it's a loneliness, isolation. It's not just a precursor to mental health issues. It's now very much appreciated. It's a precursor to general health issues. And I think it's a great shame that because we're under such financial stress as we've been talking about in other items, that, you know, when people get to a certain age or a certain disability, we just can't give them a pad, because I think that is so much that could be done with that, you know, because people could talk for hours via these things for nothing, you know, chat away face to face. And I mean, that is a fantastic tool that we could give to people with mobility issues who are homebound and can't get out. But unfortunately, we're not in a position able to do that yet. And I think that it really is a great shame, because it's a wonderful tool. And, you know, I think as soon as funding, you know, could become available, that's something I'd really like us to do, that all elderly, housebound people should be given a pad. And I think they would, you know, relish doing it. And that would then also give them access, you know, to the online GP services. You know, nobody wants to sit hours on the telephone trying to get through with that message. You know, you start, you know, you're number 43 in the queue, and all the rest of it. You know, to be able to do that digitally, I think would be a fantastic service. So, yeah, I've waffled on a bit. Sorry about that, but you know, I just wanted to make the point, you know, about, you know, our Medway services here. You know, all the time that we still need the conventional paper-based system, we will do it. Even if it's only down to 1 or 0.5% of the residents that need it, we will still keep that going, because, you know, we've got to provide universal services, and that's the point I'm trying to make. These have all got to be universal services. Yes, it's great that people are doing their shift and that they will continue to do so, but I think we will be in a situation probably for many, many years yet that we still may only have 1 to even 0.5% of people who won't be able to access. But all the time that I'm looking after our transformation process, I want to make sure that those people still will be catered for.
Thank you, Councillor Golding. No other member? I've got to be honest, Adrian, and say that your description of digital inclusion strategy, I couldn't help but think back to the first days of Neighbours, where I think there was a character called Mrs. Mangle, who was the one who kept going and understanding all that was going on in the neighbourhood. Digital inclusion hadn't even been thought of there, so I can think what's going through my mind: digital inclusion, the modern day Mrs. Mangle, if I dare. Back to you, Vice Chairman, please.
Right. First of all, can I draw your attention to the recommendations in 9, and the board, and ask the board to note the report, and in fact to support the proposal to include a digital inclusion strategy within the council's wider DDAT strategy. Secondly, to support the way forward, to include the digital inclusion strategy within the customer choice section of the DDAT for progression alongside other customer choice work streams. And thirdly, to receive a presentation of the DDAT strategy from the Chief Information Officer at a future board meeting. And I think that the work that Paul has done on this is absolutely terrific. And I think that, you know, I've seen some of it, not all of it, but what I've seen is really encouraging. So I'll move those recommendations, please.
Thank you. Paul, did I understand you saying you'd come back at a future date?
Yeah, that's right.
Right, okay, thank you. Right, the recommendation has been put forward. Are we all agreed? Great, thank you very much.
Ah.
Right, we're now going to now turn, please, to item 12 on the agenda. And I note that our two guests are with us at the end of the room. If you'd like to please come forward and join us. That's correct, is it? Yeah.
Good afternoon. Thank you for having us, and apologies that we could only be here for a short period of time. My name is Fanar Sharif. I'm a GP working across Medway and the Medical Director for the Medway and Swale Health and Care Partnership.
And yeah, I'm Suk Singh. I'm the Director of Primary Care for Kent and Medway.
Thank you. Thank you both very much for coming, all of you, for coming to join us this afternoon. Make sure I get the right item in front of me. That's it. Is this going to be a joint presentation or? Right,
yes.
Okay.
Yes.
I think we're just checking to make sure everything is working.
Oh, this one?
Yep. Okay. The floor is yours. Thank you.
So thank you for everyone for giving us the time to come and talk through the General Practice Development Plan. And there's two aspects to this, really. I'll be presenting on General Practice Development Plan, recognising some of the challenges that we've got with access to general practice. And Dr. Fern Sharif will speak about a particular piece of work that's ongoing in Medway with the Medway Health Hub, which looks to address many of the challenges that some of our residents are facing. In terms of where we are, so we've got a General Practice Development Plan, and it was approved at the first ICB board in July. And recognising that we've got 7 interim priorities for the ICB, and a General Practice Development Plan is one of those. One of the things that I think we recognise is that there are challenges that our residents experience in terms of accessing GP services. I started with Kent and Medway in May, so I'm fairly new to the system. But many of the challenges that Kent and Medway experience are reflective of what's going on across the country. And where I worked previously in South East London, they were experiencing similar challenges. But we do recognise there are differences and nuances around our populations, around our geographical spread, and issues around health inequalities which may exist. So what I wanted to talk through, and I'll go through some of the points that we've got in the slide about where we are. So we've got our pledge in terms of what we're looking to do. So in terms of the areas of focus, we're looking at how we can improve access for our patients to access GP services, and we recognise that's quite a wide remit of what we're looking to do. We need to improve patient experience in how they can access services. We need to provide safe services that our patients have confidence in accessing. And I think just to bring that home, we've had recent CQC inspections that have resulted in some inadequate ratings. And there was one case fairly recently where we had to act really quickly to get another provider in to take over the registration of that practice. I would have to say that what we need to do is obviously make sure the population are confident in the services they're accessing. But I do need to just recognise that our MP was very helpful in trying to make some messages out to the constituents. So Tracy Crouch met with the practice when they came in and took over that practice surgery, and put some really reassuring messages to our residents. So what we want to do is make sure that we continue that vein of actually providing confidence to our residents that they can access safe general practice services. We need to improve patient outcomes, so it isn't just about being able to access the service, but also look at our population needs and what the outcomes are for them. We need to identify and address health inequalities, so recognising that the pandemic threw a big light on health inequalities and how we can make sure that where there's unmet demand from people, we can support those. We need to provide a resilient and sustainable general practice, and we'll touch on this as part of the conversation around the Health Hub, but how we can support more at-scale offers of support to our general practice providers. We recognise there's issues around recruitment, and I think that was discussed earlier on in the agenda, around recruitment challenges, but actually there's also an issue around retention. So actually, how can we make sure there's ongoing development of staff, we meet their training needs, and we support them to continue to grow and develop in Kent and Medway. We need to enhance digital technology, but that shouldn't be to the detriment of patients that might experience digital exclusion. So we need to consider that in the round of what we do. And estates is really key as well. So how we make sure that we develop our estates with growing population, a growing workforce, and new service models that we want to develop. And then the final thing that we wanted to mention is just around how we develop integrated services. So how we kind of start to work with our wider system partners, recognising that general practice is one element of healthcare, and that's quite often the front door for patients, but there is a collective responsibility and issue that we have in terms of accessing services and how we can collectively support each other to address them. We started initially obviously looking at what matters most to patients. So we look at what's happening in the GP survey. So getting through on the phone is really important for patients and how we can support that. So we have started to roll out new telephony solutions in our practices. So 70% of practices have moved to a new telephony provider, which makes it easier for patients to get through on the phone, recognising as well that we also need the resourcing behind that as well to support that. We need access to appointments, so people need to be aware of how to access their appointments. People need to understand what happens with triage and why that's in place. So one thing we have recognised is our face-to-face appointment provision is greater now than what it was pre-pandemic. But we also have additional demand that comes through in terms of telephone consultations, online consultations as well. So we are actually having new methods and means of people being able to access services. What we need to do is obviously look at why we've got triage in place, and quite often it is to try and make sure that the patient gets the support they need from the most appropriate person, and how we can make sure that it's explained to people. And as I mentioned before, we do have issues around GP challenges, but there is a wider workforce in general practice that can support patients' needs, and it's about how do we make sure that patients have confidence and trust in the healthcare professional that is there to support them. Patients want to be able to access their prescriptions, so again, that link to community pharmacy is really key. Understand the role of receptionists, because quite often that's the first point of contact for patients when they contact their surgery, and we need to make sure that we understand what the role of receptionist is and how they can support that patients with their need as well. Patients want empathy when they call through, so there's some support that we need to make sure that we get into general practice, and they want consistency of care when they do get through and they get access services. So what we've put into our GP development plan is focused on particular areas, and I'll just pick out some themes from the areas that we've got. So what we've identified is in each area, put down what we will do in those areas and how we will know if we've achieved that strategic aim. So our GP development plan sees us through for the next 2 years in some of the areas that we want to address. So patient engagement, we need to make sure that we support engagement with local communities, recognising more people are using practice websites to access their surgery. Is there the opportunity now to update practice websites so patients get more information from that, and that helps them navigate through the system? And how do we continue to ask for patients' views and their accessing services? So we have the GP patient survey, which is once a year, but we need to make sure that we continually seek the views of our patients and residents and how the experiences that they are having, and whether the things that we're putting in place are having an impact on them being able to access their services. In terms of access, and this is a big area to try to cover, is I mentioned before about the demand that we've got and how it is much greater than what it was pre-pandemic. So there's some work to do around actually looking at demand and capacity and how we can look at that modelling and how we can support practices with developing their primary care offer, how we can improve access to online services for patients, increase the use of the community pharmacy consultation service, so that additional support that's available for patients from their community pharmacy, improving telephony systems, as I mentioned before, and how we can start to tackle some of the health inequalities that patients experience. We have our primary care networks that we've got across Kent and Medway, so how can we make sure that we support and develop them and how they can support our patients and residents? So they are, again, I mentioned before, we've got general practice staff, but we've also have these additional roles that are in general practice as well, and how they will support working across the neighbourhood and the community to support the patients. And we also are developing our enhanced access offer. So that's where patients will be able to access services in the evenings and on a Saturday as well. So we're getting those plans and they'll be ready to go live from October. And then the final bit is how do we continue to engage and develop our primary care networks. We mentioned about workforce, and I think just in terms of the areas, and this would have come earlier in the conversation, so we've got an attraction package for Medway, but the other thing that we want to try to do is promote general practice as a place people want to come and work, and not just general practice, but Kent and Medway as well. So we've developed a recruitment campaign program about how we can encourage people to come and work in the area. We've got estates, so again, it's looking at how we can link in with local councils around local plans, develop our estates needs, delivering against the sustainability plan, and how we can also free up space by digitising some of the paper notes that are in GP practices. I mentioned about quality and safety, so again, patients need to have confidence in the services they're accessing, so how can we support patients by making sure we get proactive care? So it isn't just about those that are seeking support for their here and now, but how can we be thinking on the horizon about patients and that need that continuity and constant support through their GP practice, and how we can improve patient outcomes as a result of that. So some of that will be linking in with public health in terms of the prevention agenda as well, and how we can support proactive interventions with our providers. The next bit is also around technology. So we've got some technology that we've rolled out, but actually how can we start to develop and evolve that as well? And looking at things around remote monitoring for patients, and also to the extent to which digital exclusion exists, and how we can make sure that patients aren't left out by the fact that we're moving forward digital technology. And we'll touch on the Medway pilot as well for the Health Hub. We've also mentioned then also about a financial investment as well. So we need to make sure this plan has the finance that will support its development, and make sure that it will recurrently support the ongoing needs of our providers and needs of our patients and residents. The other thing I just wanted to mention as well, so since we developed the GP development plan, there has been a national report published called the Clare Fuller Stocktake Reports, which looks at actually, and it does link quite nicely into what we're doing with the GP development plan, but seeks to go a bit further. So it's how do we evolve our primary care networks to create integrated neighbourhood teams, and that's working with our community partners to support our patients better. How do we improve streamlined access so patients know how they can get supports and there are urgent integrated care providers? How can we get personalised care to those that need it? How can we help people stay well for longer? How do we look at our local needs? And how do we create that capacity, whether that's looking at workforce, digital and estates? And then how do we build sustainability? So again, it's that ongoing need. So we're not just in the here and now, but addressing the longer term service provision for our patients and residents. The plans that we've got here are quite ambitious, but they are focusing on the here and now issues that we've got. We do recognise that there is a longer term plan that we also need to develop for the next, beyond the next 2 years. But what we do want to do, and with the support of our colleagues, is develop a general practice offer that meets the needs of our residents. And also we need to look at making sure that our staff in those services are also supported. But I think this is, what we want to do now is just speak about something that's going on in Medway, which does link into some of the GP development plan, which Fern will talk through.
Great, thanks. So following on from this, our aim really with the Medway and Swell Health Hub is to collaborate our efforts and to work across multiple practices with our system partners to balance patient need as effectively as possible with the resource that we have. And we've met as a group of clinical leaders, so there's 12 clinical directors. We've all sort of developed a sort of vision across the system, which is to deliver equitable, high-quality patient care through collaboration. And we believe that the Health Hub is our first step in actually achieving this. So this is currently a virtual model. It's been developed by 7 local GPs working very closely with the ICB digital teams. It's in its very early stages of development, and we think it'll take about 2 to 3 years to be fully established and embedded across our primary care networks. It essentially aims to provide additional capacity in managing patient access on behalf of primary care. Why do we need to do this? Well, we know that the number of patients across practices is now 22% higher than it was about 6 years ago. We also know that we don't have enough doctors, but what we do have is a wider primary care workforce that we can work with to meet our patients' needs. And we also have an increasing number of patients and practices that are using online consultations. So this is essentially one form of accessing support. It doesn't replace face-to-face consultations or telephone consultations. It actually adds to what we're already providing. Oh, I need the little clicker thing. So the Health Hub has essentially has got three components to it. The first component is the triaging and actioning of e-consults, and we're trialing this initially across 2 of our primary care networks. We're also piloting a virtual pharmacist to carry out structured medication reviews across one of our other PCNs. And the third element to this is we're developing virtual wards to support both adults and children with respiratory conditions. We're also working with an independent consultancy so that we can effectively engage with practices and patients, and we can get their feedback at this very early stages of development and actually build that feedback into the model as we continue to develop it. The good news is that we've successfully managed to recruit 2 GPs. We've also got 3 nurses, and we've got some admin staff to help in managing the workload here. And the idea is very much to divert the e-consult queries away from practices to a centrally coordinated hub that will deal with the query on the practice's behalf. We've developed a matrix. Our GPs have developed a sort of matrix, which is essentially a guide to help the triaging team in managing patient queries. So the hub has access to the patient record. We're able to prescribe. We're able to refer on to other services. We can arrange face-to-face appointments where needed, and this essentially means that practices will have more time to deal with their own admin, their own face-to-face appointments, and spend much more time with patients that might have more complex needs, whose needs can't be dealt with virtually. And with the health hubs so far, it's encouraging to see that over 90%, I think it's around 98% of queries coming in are actually dealt with within 1 day. None of our patients so far have gone into hospital, and the majority are actually managed in a primary and community care setting. I think that's it from me, so happy to take any questions.
Thank you very much for the presentation. Most informative. Any member, please. Vince and then Howard, please.
Yeah, thank you very much. Really helpful and a really good starting point to life with the latest edition of the NHS alphabet soup for Kent, Medway and the rest of the country. I just wanted to pick up on, I guess, 4 things at this stage, really, and say thank you for the presentations. On that most recent example, it's great if the MP was helpful. It's less great if elected councillors are hearing from the press about the situation. That needs to be better. That needs to be better. We can't have elected members of any political party finding out something of this nature, which of course is generating concern in the community. And it's not the first time that Medway's regrettably had these circumstances of urgent change of provider. So I'm sure that will be a lesson to be taken up, and I'm not sure, actually, I've been trying to check in the last few minutes, I'm not sure yet whether the NHS have actually contacted the councillors at all yet. They may have done, but certainly I'm aware that they didn't find out from the NHS of that circumstance, so I'm sure that will be a lesson learnt moving forward. One of the challenges, and I absolutely recognise this is not a Medway issue, this is a national issue. You know, you start with the point of people love their GP, and that in itself is an issue that across society you'll have some people who will be determined to see the same person they've seen for 30 years, despite the fact that that person probably wanted to retire 20 years ago, but their passion and determination to help their community remains. And you've got people who are definitely younger than me, who probably have no regard for a named GP. They just want to see somebody or get some advice, you know, potentially online as well. I guess one of the challenges, and you will of course be aware that it has been a trying matter for elected members on Medway Council on a cross-party basis. That's why we've chosen it as our ongoing task group. Some of the challenges around consistency. So actually, some of the GP surgeries in Medway you can get through to at 8:01 and probably see someone that day face to face, and that's brilliant. For other people, you will genuinely be number 80 in the queue. And I think that's the biggest challenge. And again, I know, and I would support you in saying that's not unique to Medway, but respectfully to the rest of the country, I'm only really worried about Medway. It's great that you've got the plan in place at your first meeting. That's great. I want to get a sense of, you know, we've got a cross-party task group looking at this issue. I would hope that that will be able to reflect, certainly, it will come up with a series of recommendations, which I'm sure the Cabinet will endorse. And just to understand that that will be a meaningful process, I'm sure it will be. And then I guess just finally, and this goes back to the first agenda item, which we were talking about the kind of last 2.5 years of COVID. That wasn't anybody's fault, but everyone's now having to deal with it as a result. And in particular, I've got a real concern around particularly men, but not exclusively men, because men are pretty rubbish at going to the doctors at the best of time in many occasions. I think the stats show that. So to try and encourage somebody to go for their 40 to 74 check, and actually if they build up the courage and confidence to do that, and then they're number 80 in the queue, I guess it's around trying to have, and e-consult is a national thing, I accept that, but whether there's any ability to have some local stuff working with James's public health team, for example. I don't want to be in a situation where in 2 years' time this board is talking about cancer rates increasing, and they didn't necessarily have to if we'd put some things in place to try and reduce that. And that's everybody. That's not GPs, that is the whole system. And again, that's not just a Medway issue, but for me, that's the thing I worry about the most from a health perspective, is there are people who, and on social media you see it all the time, someone's been referred, they've got to see their GP, but then the next part of the system isn't working. So they were referred for a process which should have been done, and the process should have been concluded within 18 weeks. They haven't had the second appointment yet in that process. So even if the GP bit is working, it's where the other bits of the system are under pressure. So in conclusion, Chair, if you can sort out all of the problems of the NHS by the end of this meeting, I'll be very grateful. I recognise that's probably not going to happen, but I'm really grateful that you're here and grateful that there's the willingness to have that engagement, and that's important. And I think that sends a positive message, because not least I think there's been some, I think, justifiable concern that from a Medway perspective, we have, with the recent changes, it puts us in a weaker position. Having our own CCG and then not having our own CCG, is that going to help? It probably isn't. Thank you.
Yeah, if I may, I think the most telling statistic in all of this is, under what matters most to patients, was the fact that 41% of the respondents reported they were satisfied, or in other words, 59% didn't. And I think that that's a number of things arise from that. First of all, I think there's an enormous resource being wasted in trying, not only in trying patients out, but also actually through the receptionists and so on. And also, if one looks at those time limits, you're always being told, or at least in my case of the when I try to contact a doctor, one is always being told of all the various things the doctor doesn't do, anything to help, which actually can take quite a litany of things. And I think I welcome the idea of setting up new systems that use the the digital age, as it were, to communicate. I think that's very important. But I think what is particularly important is, I know doctors value their freedom, and I don't think that's up for debate, but I do wish that we could get a system that all doctors use, because when you look at that 41%, I'm sure you would find that it is 100% virtually in some areas and 100% the other way in other areas. And I think that, well, near enough anyway. And I think that what needs to be looked into really is can we not get all of the GPs to agree to use the similar contact basis, on the basis that it's cheaper, on the basis you'll get a unity of purpose, and if there are any failures, they'll all go down the same route, if you see what I mean, and they can be dealt with. And it seems to me that would be one of the really outstanding points of this, because as we always say on the council, really, and in some cases we don't achieve it, and that's what David and I spend our life crusading about. But you know, the first point of contact, it seems to me, is absolutely vital. If a patient gives up on that first contact, which often can happen, and I suspect does more than most people would admit, then frankly, you're only going to get that contact either by the person turning up at A&E, or you're going to just simply see that they rush to hospital about a year later, you know, with something very serious that may or may not be able to be fixed, which could have been fixed then. So it does seem to me that you know, the adoption of a single system in the areas that we know that are good would actually help the process enormously. And, you know, I think one obviously would have to sell it to the doctors, but I don't think it really needs to be sold in, because I think that what is bedeviling doctors get very frustrated by this. Receptionists get frustrated and they hate it in some cases, because by the time they talk to people, they're pretty fed up, you know, and so on. And so I think that's the area I would start with, and I'd really try and get that right, because I think until that's right, then nothing else, in a sense, will follow from that's right. I think that, you know, you've got to get that initial contact correct. Once that's happened, I think that taking advantage of the fact that you don't need as it were, a brain surgeon to deal with someone who's got something wrong with a big toe. You know, I mean, it's and I think that we, to a certain extent, GPs are a very expensive resource, if I may put it that way, which we often deploy to deal with things that I think bore the hell out of the GP, because it's, you know, simply taking, you know, it's standard lick'em and stick'em stuff. And I do feel that there is a real opportunity there to have professionals of a lesser, you know, rather in the same way, if I can use an awful expression, you go to a garage and you get someone diagnoses the problems, but it isn't the person who fixes it. And I think that, you know, and if they can't diagnose the problem, they know enough about the car to say, I can't do this, this needs to go to the chief engineer. And I think we can actually do that, then that I think would actually help a lot. Now, whether that means skilling up the receptionists to be able to do more of that, or whether that means putting somebody else in that you know, an intermediate there, I don't know. But it seems to me that those are the ways in which you can ration the service without it actually suffering. And if everyone works to that same principle, then you start to get a system that is coherent. But at the moment, I don't think the system is coherent. And certainly, you know, a lot of patients are dissatisfied with something which I believe could be easily cured.
Thank you, and thank you very much for joining us this afternoon, because, you know, GP services are really the front door to the NHS for most of our residents. And just to sort of follow on from my colleague Councillor Doe, we've got to accept we do have a real issue with accessibility to GPs here in Medway. We can't ignore that fact. It is, in some areas it's far worse than others, but certainly the area I represent, Walderslade and going into Princes Park, there is a real problem. And I can personally give yeah, sorry. You know, I've certainly come across at least 2 cases in the last few months where people have unable to get a GP appointment for a young child in their family, have had to take that young child to Medway Hospital's emergency department. And we all know that the emergency department at Medway is under huge pressure, but it's not fair that they're put under even more pressure because they can't get an appointment at their local GP practice. And I have to say, you know, resorting to Medoc is not a particularly good way through either, because people there get left hanging on the phone and not able to get through. So Councillor Doe mentioned that GPs are a precious resource, a very highly qualified resource. We need to use them better. I think that's certainly the case. And I'll just give a personal example I've witnessed a long, long time ago, it was probably 1975 or 1976, when I was a young merchant seaman, I had an accident aboard a ship just literally a couple of hours before the ship was due to sail. So I was taken up to the local doctor's surgery in Long Beach. Long Beach in Los Angeles is definitely, as our American friends say, the wrong side of the track. So I'm not talking about a wealthy area. When I went in to see into the doctor's surgery, I was first of all seen by a nurse who took all my details, gave me a quick poke around to see what the problem was. I'd hurt my back. Then the doctor came in, picked up the clipboard, and he knew exactly what had happened to me. Told me, oh, you need an x-ray taken. So the nurse took me off. They had their own x-ray machine in the doctor's surgery. While I was waiting for the results, I realised what was happening. There was actually 2 surgeries, 1 doctor. There was a nurse in each, and the doctor was going backwards and forwards between the 2. He was just doing the bit where his superior knowledge was needed. The 2 nurses were doing the introductory bit. You know, so simple but so effective. You know, the turnover rate through that was fantastic. You know, we need to think of things like it's not rocket science. You know, it's just thinking just slightly out of the box. There's lots of things that need to be done there. Before I finish, I can't but not mention Prospective Healthy Living Centre here in Chatham. This is a project that I've personally been working on because I have responsibility for Medway Council's property, which includes the Pentagon Centre, where we hope to get the Healthy Living Centre. I can't fault the people involved in that, but this has been dragging on and on and on. Nobody seems to be able to make a decision. I mean, they're all very nice. You know, I've been invited to join even the ICP Estates Forum, which I attended a few weeks ago for the first time. But nobody seems to be able to make a decision. So here we are. We're talking about a £10 million plus project to provide what hopefully will be superb facilities for our residents here in Chatham. But the health service can't get its act together, you know, to get the thing sorted out. You know, it is so frustrating. You know, I've literally been tearing my hair out over this project, and so have a lot of council officers. I've got another meeting on it next week. I'm probably spending more time on this single project than any other project I've got here in Medway, and that includes the Medway Development Company. So, you know, there are a lot of things that are not working well for the health service, and certainly the estate side is one of them, is not working. We're not getting enough GPs. I read a frightening statistic a little while back that the average GP is only working 2.5 days a week. Now, how have we got to that situation? You know, there's some really serious issues that, you know, we need to get sorted here. I don't say these things lightly for just the sake of, you know, trying to be critical, you know, because I don't want to be critical. I want to help. And this is what this board is all about, is by helping. But we do have, in some parts of Medway, and it's certainly in the area I represent, a major problem for our residents to get access to their primary care.
Thank you, Adrian. It does appear if you want access to the estates, I think you found the right people, because in fact that's the very first item that I wrote down when you started to speak. Contact with estates. So there you are, Adrian. Looks as though you've got a door that's begging to be pushed open further to get that help. James, you wanted to come in, please.
Thank you. Thank you. It's just because if there's more mics on, members, I just wanted to reflect in that discussion, and I was making a few notes. I'd pull out a couple of 3 things. So one was around the challenges that we face around workforce. I think Becca's already given us that overview in relation to we're not going to be able to get those GPs in place overnight, and I think we all recognise that. And one of the other bits that then, as we were talking, came through. If we look within the model that's been set out, in particular the health hub. So the bit about triage, I think Councillor Murphy referenced whether there were other people that could get trained up. So in that model, it does set out, you know, that whole thing around using, as you've just said, Councillor Gilvin, nurses to do the work, to actually identify what needs to be done, and then refer those colleagues or those patients, my apologies, into another person. It could be a GP or it could be another specialist. So I think if we look at that model, it probably does give us that sense of we're trying to make the best of the tools that we've got. I think you mentioned the Healthy Living Centre. I'm going to come back to we need to move upstream because obviously this is the Health Wellbeing Board. What we should be trying to do, I know that is what we're considering at the moment, is look at the things that we can do to build greater resilience into our communities. And then it means that we reduce the demands on whether it's primary care or secondary care, whatever. One of the elements in that model is the social prescribing model, the voluntary sector. I'm looking over there. And their role in terms of providing additional capability for us when you get folk signposted through to that. So I think the message is I can't go there, of course, on the Healthy Living Centre concepts, Councillor Gilvin, but we do need facilities. But I would like us to just think about the model that we employ and actually the ability that we have got in the short term to develop more interventions that are going to reduce the likelihood of people needing to come forward. That is a big challenge. And at the same time, getting that model right. So within the Healthy Living Centre concept, the wraparound, we had a presentation at CMT, I'll look to Leanne, but I'll fast baller, from the DWP, so Department of Work and Pensions, and the work that they're doing to identify people who can come into the care sector. So they're actually sat there, they've got Sue's team who are actually down there in the actual facility, the interview folk who are unemployed, they come in there, there's an employer that's sat there that can look and work across. A lot of those people, unfortunately, got long-term health conditions, but getting them into work is one of the good ways, I think, about balancing out some of the mental health challenges of the bits and pieces. So my observation, just, and if I might, just as TPH is, I think we recognise that there is a big challenge for us with the GP workforce, and I think the GPs know that themselves. And what they're trying to do, from my perspective, in any event, is to come up with some kind of creative solutions that will bridge the gap. And I think that is what I've heard. But again, I think there is, what more can we do to support, which is, I think, your point, Councillor Doe, those colleagues. And I think we can do more. I think we can be a bit more creative in the way in which we look at this issue. And I go back to the P&A in there, the role of community pharmacists, because we just had the pharmaceutical needs assessment. How do we actually get that skill mix? How do we actually bridge so that GPs and other colleagues can use that resource to pick up some of that burden? So just a couple of thoughts from the presentations that we had previously.
Thank you, Chair, and thanks for this paper. I really enjoyed reading it. I think you ticked all the boxes. You know, I think it's a really comprehensive go at trying to do something. And yet, I had to try reading it again because there was something missing for me. And I think it's the starting point. You know, you talk about pledges and vision, and it's got our vision, general practice is the bedrock of the NHS, and I'm thinking, no, it isn't. For me, general practice is the bedrock of humanity. It's, you know, access to medical treatment is a human right. Half the world's population wouldn't know what an NHS is, but they would know that they wanted and they deserved, you know, medical interventions when they needed it. So it just kind of started a bit wrong to me. And then I read through and I still didn't know why I was feeling like that. But then I got to patient engagement and it said, we will do this by, and that was the key for me. No, you won't do it by, you'll do it with working with people. You'll do it by listening to people. You'll do it with people. And that took me back to the SEND strategy we were just discussing, and a really solid, strong point in that was co-production. And I think that's what's missing for me in this is the co-production, and many of the much of the narrative this afternoon has been personal narrative about working with. I absolutely agree with James about there are other medical partners who can absolutely play a big role in this, the pharmacists. Making use of other parts of the system is really, really important. But I do think we've got a bit of re-education to do as well. You'll probably hear I'm not from this country, so my first point of call if I need medical anything is never the GP, never. It's the pharmacist. Because where I come from, you have to pay for to go and see your GP, so you're not going to do that as your first point of call. And it's kind of stood me in good stead, really, because I do deal with the pharmacist first and take their view and try some of, my own remedies or whatever. And if that doesn't work, I'll go to the GP. But quite frankly, when I go to the GP, it's not good for my health. It takes me hours to get through. My blood pressure goes right up. I'm sitting in the reception room thinking, how long is this going to take me? You're surrounded by sick people who just don't know what to do. So when somebody talked about the system being broken, I think that's absolutely right. But I really love this. I really do. I wouldn't, but it's just missing that human element for me in the co-production, and how all of us, James's point about being further upstream, the whole prevention, how that can impact on this development plan, because then I think Medway and the rest of Kent is going to be in a brilliant position. So thank you.
Thanks, Chair. Got a few points. I suppose firstly is just to provide some assurance that pre-COVID and since COVID, for years we've been working with not only seeing a GP but seeing a nurse, practice nurse, nurse practitioner. That's been in existence for years and continues to be. So just wanted to put some assurance back that we're not routing everything through the GP. There's a whole diverse range of health professionals that are at this first point of contact. I suppose building on that as well, what we're trying to do with, and I'll come on to the health hub in a second, what we're trying to do is not look at primary care in isolation. So as a system, we're trying to say, actually, how does primary care become an integrated local care model? So why are you accessing the GP? Why are we accessing other health professionals? So try and do it in a coordinated response. So the ambition of the health hub is the e-consult, as Fern has articulated, is just the first stage of that. We're just dealing with the e-hub, e-consult part. But the second stage, I think, comes into the point around sort of one system. What we're trying to use the health hub for is a single point of contact for all primary care. And then from there, we triage out to the most appropriate place. So actually booking into your GP, it can either be digital or through phone, but actually be a pathway. So we're looking at working with the GPs at the moment is how we access their booking system, that if someone contacts the health hub, we can directly book either to outside access through Medway or in hours through a GP. So that's what we're trying to do. We're working with 2 PCNs, 2 primary care networks at the moment. So the first stage of the health hub is just the e-consult, but then there's 4 or 5 stages to that, and we're trying to roll that out geographically, but also through the stages. One of the big things that I think was alluded to earlier as well, presentations at Medway or at ED, we know there's a number of primary care presentations there as well. So one of the things that we know the usage of that is it's quite close proximity to the acute trust. So again, what can we put in there? So we're trying to, rather than just look at primary care in isolation, and obviously we want to recruit GPs, but again, it's not just the answer is the recruitment of GPs, it's the wider health professional and the wider workforce. So one of the solutions is how do we integrate this in single, like one system access point in, but then the appropriate triage to see the appropriate professional at the right time. And that's really where we're trying to move it forward. And in terms of co-production and co-design, yeah, it may not have come out in the presentation, but this is all being done with engagement with patients, with users, and with GPs themselves and with the professionals themselves. So it's a wide stakeholder group. We're looking to develop this because it's not just the experience of the patients, it's the experience of some of the staff providing the services. It's a change of clinical practice. It's a change of clinical expertise. So working with universities as well. So this is not going to be solved overnight, but some of the ambition is there. This is the first start of it. So the presentation on primary care is one part of it, but it's actually the whole health and care system is trying to change that and trying to change the access points into it. Otherwise, we're always going to be on a point of number 50 on a queue, number 60 on a queue, rather than actually, can we look at how we access, and then from the primary care perspective, what does a GP need to do that only a GP can do? And actually what can be diverted else off to other things. So I think maybe it's a later stage, it may be worth bringing back some of the thinking on the wider strategy for what local care looks like, because primary care is one element of that. But over time, really, the single point of access for community services is where that has to merge with primary care. So you access the most appropriate service, but through one system. And that's what we're starting to work on. I just wanted to bring the board some assurance that it's wider than just this singular aspect.
Okay. If I can just add a few comments of my own, please, because it's been interesting reading the presentation, listening to the presentation as made, and listening to the comments being made from around the room. And really, I can't help but think, well, how on earth did we get ourselves in this mess in the first place? And then I started to think back to STP. Now, some of you in the room may not even know about STP because it all started so long ago. It seems to be lost in, the name seems to be lost in translation. But it was a transformation, sustainable transformation program that was being looked at to be installed right across Kent and Medway. We were all going to come together, Kent and Medway. And by doing all of this, not only would we be improving the service, but we would be saving the NHS considerable sums of money. Now, I've been sat on the STP board and the subsequent boards that followed. We even created a joint Kent and Medway Health and Wellbeing Board for the duration of STP so that we could follow through on the strategy, because Health and Wellbeing Boards is about the strategy, not the nuts, bolts and washers of an overview and scrutiny committee. We were interested to make sure that the strategy was correct. And as we've gone through that programme, I think we've lost our way in as much as that one of the items that I clearly wanted to understand at the end when we wound up the Joint Health and Wellbeing Board was, well, how much did STP cost us? What were the savings? Well, I think I'm going to probably have to wait for hell to freeze over before I get an answer to that. And I mean that sincerely, because we did all this STP, it was down there to save money. That was one of the objectives, to improve service and to save money. But when you ask the question, what services have been improved and how much money has been saved, you come up against a door that is stronger than being fixed to Fort Knox. You just can't get inside to find out. And I think that's a terrible indictment of something that we all embarked upon. And the local authorities, we were not invited, we were told that we had to be part of that STP programme. And so you get a feel for our involvement across Kent and Medway. As STP came together with its plans and progress and where it wanted to go to next, we had to go to London, and we made a presentation to the representative from the central government and the NHS as to exactly where we were with STP. And at the end of it, during that presentation, the chair of the board actually congratulated Kent and Medway on their presentation, but moreover, he made mention of the fact of the contribution and the presence of the number of members, representatives from the community, councillors like ourselves, who were there for that presentation and to lend support to all that was being given. That's what we got. We were highlighted for the support that we were giving. We seem to have been left out in the cold ever since. We've done our bit. We've contributed. Therefore, we don't need you anymore, local councillors. But thank you very much for what you've done. But what has effectively happened is that the local councillors, and Vince mentioned this earlier, is the fact that we really have been the first port of call for all of Medway residents when there's been a problem in how can they get hold of GPs, where are the GPs, how we got to, Martin says, number 50 in the queue, number 60 in the queue. Our phones were red hot. Nearly 24 hours of the day, people were contacting us as local councillors to find out what on earth is going on. And sad thing is that we couldn't give them answers. This came to the Health and Wellbeing Board over a year ago now, and I remember it distinctly that a member asked for this item to be raised, and I had to point out that as a Health and Wellbeing Board that we were interested in the strategy. And our request was for the STP, ICP, whatever it may have been, we wanted information and we wanted details of the strategy that was being put together to improve and overcome all of the issues that were being experienced across Medway. But we then found out it wasn't only Medway, this was across the whole of Kent. So we were saying, come on, what is your strategy? That kept on going on and on and on. Three meetings we had, 3 times it was on the agenda, 3 times people failed to come and present any issue to this committee or to this board. We were left in a state of limbo. In the meantime, the Overview and Scrutiny Committee have actually picked up and got down and formed a task group to look at some of the issues. Why should a task group for Medway Council have to look at the issues when the organisation, the people responsible for putting this together, weren't doing anything? Or if they were, they certainly weren't reporting it to any organisation, and in particular, not coming back to the Health and Wellbeing Board. So I'm not going to look at you two and say you're to blame, but sadly, if you like, you're the messengers here today, and I have no intention of shooting the messengers because I found that probably the 2 messengers that we have here today are probably more knowledgeable on what is really going on in Kent and Medway in particular, than anybody else that we've ever spoken to. So thank you very much for the presentation. Thank you very much for the first pass to find out what the strategy is about and how long it's going to take to implement that strategy. But at the same time, please don't think that anybody in Medway is going to forget the mess that you got us into through the NHS and the services that were failed to be delivered. It really has been, it's been horrendous. It really is, and it's difficult to find the words to really express the frustration that the people of Medway have felt over the last 2-3 years. Everything was blamed on pandemic. But as we come out of the pandemic and things begin to ease down, I think a lot of people are thinking, pandemic, was that really the cause of the problem that we have? Or was this the original, the STP, and their failings to put into place what should have been put into place? And that was a steer to where we needed to be in the strategy. Now, the fact is that we have here today Jane Black, who's the newly appointed Chief Executive of Medway Hospital, MFT. And congratulations on your appointment, by the way. But the fact is, as one of my colleagues has said, Medway Hospital has been filled to overflowing with people at the front door waiting to get in to see somebody in the hospital. Several examples have been given. And as a councillor, believe me when I say that our phones have been red hot. But just to quote a couple of examples. One resident phoned me up and said that they'd phoned the 111 service. Recommendation, well, we can't get an ambulance to you there quick enough to do what you want. You're saying that this is a bit of an emergency. Best thing you can do, the family member on the end of the phone was told, best thing you can do, take your relative down to the front door of Medway Hospital, open the door, put him in front of the door and then drive off. And honestly, this comes from a local resident. And if it hadn't have been for things like that, what sort of service are we running if people are being told that's the best way of dealing with it? Drop them off at the front door of Medway Hospital and they'll sort the rest out. That's not the service that's needed. A couple of weeks ago, finally, this is my final point. A couple of weeks ago, I needed to have a blood test. So I phoned up, got through, spoken to and dealt with quite speedily. When I asked for an appointment, I was told, well, we can fit you in 7 to 10 days. Eventually, a date was given, and I was told to be there at 10:23. Okay. Told to be there, please, at 10:23. But please be on time, because we're a very busy service. So I got down to the Health and Living Centre on time, parked my car, went to the door. The place was absolutely deserted. And I went to the reception and I said, I've come here for a blood test. Oh, there won't be a moment. Literally, I was pulled through the door and through to a room to have my blood test. When I started asking questions, oh, I think you're very busy today. Oh, not really, this is a slow day today, slow day. I said, is it like this every week? Oh, well, most days, it's we're not really pushed at all. I was literally dragged in because there was nobody else there waiting for a blood test. However, I was there at 10:23 on the dot. So I'm giving these as a couple of examples that these are the sort of things that come to us as counsellors. And that's just a couple of experiences that have come to my personal notice. But anyway, thank you for the report. You've started off by telling us how the strategy is coming together. It is the plan, and we're obviously wanting to know and follow this through to make sure it is implemented as speedily as is possible for the benefit of the people of Medway. They're the people that we're after, Medway. And I've said it in full council meetings, overview and scrutiny. Personally, as a local councillor, I'm rather focused. It's Medway, Medway and Medway. So please bear that in mind. My Vice Chairman, please.
Will the board... Sorry.
Just two things. It may be helpful to hear from colleagues before we finish this item. I'm conscious of time.
Yeah, thank you, Vince. Thank you.
And the second thing I would say, in fairness, we had a report a year ago today which talked about those health issues. So I understand, I have that frustration. We all have the frustrations. We can see the plan is in place. And I look forward to seeing that.
Thank you very much, Vince. Can I pass back to the Vice Chairman, please?
Right. Okay. The board, can I ask the board to note the presentation on the General Practice Development Plan 22 to 24, and may we have a progress report on this up to an appropriate meeting? I know you, Chairman, would probably tell me when you think they should be, but I think we need to keep tabs on this to see it's actually doing what it says on the tin.
Okay. Can you suggest a date, please, Jade?
If I may, I'll liaise with colleagues outside this meeting.
Yes.
Okay.
Yes. Okay.
That'll be fine. So the date, on a date to be advised. Are we agreed then, please? Agreed. Thank you. Right. Thank you. Thank you, everyone. Just for.
Thank you for having us.
Adjournment. Quick. Yes, I think so. Well, it might be an idea if we had a very quick 5-minute comfort break. I think that would do everybody the power of good. Thank you very much. very careless of us, I know, but he's loitering around the building somewhere, but we're very conscious of the time. So we're going to move on now very quickly now to item 13, which is Violence Against Women and Girls and HMPPS Reducing Offending Plan 2022-25, to be found on pages 277 and 308. So could I just welcome, please, Assistant Chief Constable Tracy Harmon, who's with us this afternoon. Tracy, good afternoon. We have Police Sergeant Matthew Dijon, is that right? Thank you. Pleased to see you. Miss Mary Pilgrim, Regional Probation Director, Kent, Surrey and Sussex, HM Prison Service on probation. Pleased to see you. And Mr. Siomak Daneste Poor. And I hope I've not made a mess of you, but Siomak is the head of West Kent Probation Delivery Unit for Majesty's Prison and Probation Service. A very warm welcome to you all. Thank you for giving up your time to be with us. And you're going to give us a presentation, as I understand. And I believe, Tracy, you're going to be the lead on this one. Is that right? Good.
Yes, thank you.
Over to you then, please. Thank you.
Thank you, Chair, and you've kindly done the introductions for us, so that will save some time. But really grateful you've invited us here today. I've come along from behalf of Kent Police to talk just quickly around our Violence Against Women and Girls strategy, and more importantly, how we move into year 2 of that, which becomes much more partnership focused. So I'm really grateful of the opportunity. And then I'll pass to Mary, who you've introduced, will talk through the reducing reoffending plan. So there are some bits in both that probably overlap, hence we thought we'd come as a bit of a double act. So I'll try and keep it high level. I've only got a few slides, and I'm really happy to take questions if I don't go into enough detail, but I'll try and keep it simple for today, if that's all right, just because of time. So violence against women and girls, sadly, most of you will remember obviously the sad death of Sarah Everard, which really did put this on the agenda for the government and has been a priority for policing for a long time. It's not new, sadly, violence. And up there on the presentation, you'll see that we have a duty to deliver not just the serious violence strategy that has now been in for a couple of years, but also the harm from hope 10-year drug strategy. Clearly, most people will see the link between drugs and serious violence, but also now the violence against women and girls, particularly because of how disproportionately girls and women are affected by certain crime types. And sadly, as I say, Sarah Everard's sad death was the catalyst for that. So year 1 has been very much focused around police activity. That was government-led, but year 2, which we'll be going into in March, is really going to be focused around more of the partnership space, and so hence my coming to speak to you today just around some potential opportunities, and also to let you know about this agenda and how it may sort of overlap with anything you're doing yourselves. So on the right there you'll see 5 key pillars. There's 3 key pillars in the national strategy, but we had a series of public events, engagement events across Medway and wider Kent in the sort of latter end and beginning of this year, where we spoke to a lot of women and girls, stakeholders, and men, obviously a lot of people who are fathers, you know, husbands, sons, etc., all feel very strongly about this agenda, and they helped to shape our strategy for Kent Police. So 2 more strands were added. Those 5 really focus on holding offenders to account. So very much, sadly, the system, I think, has been focused around victims, especially the court process, and really it needs to be much more offender-focused, offender-centric, and we need to provide that focus of targeting the highest harm offenders. Supporting victims, so making sure that we make a victim's journey as easy as it can be, making sure the support is in place for them to not only just come and report to police, but to enter the criminal justice system if that's what they wish, but also to look at other out-of-court disposals and options for them, because obviously not everyone wants us to prosecute. Keeping you safe, this is really around the open space, the public space, I suppose fear of crime and how women and girls feel in the community when they're walking around their own communities, using public transport, etc., etc. So a really key pillar for us. And then the two that we added following sort of like the local engagement events and consultation was really looking at our own culture. It's not lost on me, sadly, that the offender against Sarah Everard was a police officer. I think we were all absolutely shocked. But it does show you that we are reflective of society, and sadly that means we do have some behaviours within our own service that we want to stamp out, but also how we then interact and share that behaviour with the public, more importantly. And strengthening the system, this really is about, as I say, policing has been around for a long time. Obviously tackling violence has always been one of the key priorities for the police, and holding offenders to account is probably, we're the only agency really that does that with the support of the wider criminal justice system. But really holding offenders to account is very much police daily business and what the public expect of us. So strengthening what we already have, and the government have legislated for some of that in terms of preventative orders and some control mechanisms around offenders, but also around how we use technology and just strengthen things like the response we give to victims. We've heard it from sort of our GP colleagues, but the demand is significant, and making sure that we use best use of technology to provide an immediate and more rapid response to people rather than the old-fashioned wait for a car to come round when one's free. So they're the sort of 5 pillars that we are working to. As I say, year 2 is partnership. Now, this is such a cross-cutting agenda. It has interest from not only, I imagine, yourselves and the wider Integrated Care Board, but we have community safety partnerships are very involved around this. We have our own Medway and Kent Domestic Abuse, Sexual Abuse Executive Group, which is our strategic DA domestic abuse group for the county. We've also got the Kent Criminal Justice Board, obviously are very interested in how we are prosecuting and helping victims through the court process. And we have the partnership safeguarding boards, both for adults and children. So there's lots and lots of partners and boards and governance in the county that are interested in this agenda. So been trying to place it into a partnership space has been quite tricky. But at the moment, we've done a round of briefings, of which this is one, and our suggestion is it's going to sit within the Domestic Abuse, Sexual Abuse Executive Group, because a huge amount of violence against women and girls is domestic related or sexual related. The one strand that is going to sit elsewhere is going to sit in the Joint Chief Executives Board with the district councils and obviously Kent and Medway, because it's very much linked to community safety, because it's about public space and environment. So that's the one strand that is going to sit outside in that governance process. So the reason I'm here today, I suppose, is just to sort of highlight a few things that are coming up and a few issues that I think are probably more health related, that we may be looking for some support, advice, guidance on in year 2 really. Most of you may know we've got a serious violence duty that's going to come into effect in January next year. So our violence reduction unit, of which some of you may be partners across the county, are already looking at how we implement that, but that's going to provide a duty, statutory duty on most agencies to report and support our response to serious violence. We know that the Violence Reduction Unit have probably for the last 2 or 3 years received a lot of money from the government. We're one of the very well funded VRUs, and we've got another 3 years worth of money, so there is a lot of money available for us to make sure we're looking at preventative measures, stopping people getting involved in serious violence in the first place. And that is also twinned with, James is very kindly, I think, for Medway, accepted the chairship of the Combating Drugs Partnership, which is part of the Harm to Hope strategy. So there is this interplay, I suppose, with lots of different partnerships having a role in this agenda. Some of the preventative orders that are being piloted across the country and are going to be rolled out next year are things such as domestic abuse prevention orders, stalking prevention orders are already in, but they're going to give us a lot more ability to put conditions around offenders, and some of those issues that offenders have, as you would imagine, are linked to either alcohol, drugs, housing, education, employment, mental health. So certainly, as people sometimes refer to it as a toxic trio of drugs, alcohol, mental health, is significant in an awful lot of our offenders' backgrounds. So looking at how we can work maybe better with health services around referral pathways is going to be a key priority for us, because it's all about trying to prevent that harm happening in the first place. And also the two-tier systems for cautions, so out-of-court disposals are going to be much more focused around conditions and programmes that offenders will have to go on as an alternative to going through the court system. And again, sadly, as I say, some of those areas do link to health needs, so hence me coming here today, really just to say if there is any thoughts, ideas, work streams that you're already working on that we can maybe link in with for next year, that would be really useful when there is money available in our pot. That's how I'm going to keep that sort of quite short and sweet for me, if that's all right, and it probably leads quite nicely into Mary, because I've mentioned some of the outer court work. Obviously, Mary's team tend to deal with the offenders at the other end, so I shall pass over to you, Mary.
Thank you, and I welcome the opportunity of coming here this afternoon to go through. So I'm here to present the Reducing Reoffending Plan for 2022-25 for Kent, Surrey and Sussex. And with me I have Siamak, who's the head of West Kent, so we'll be able to go into any specifics or questions that you may have going forward. So just in terms of the contents, and the next slide, just to say, obviously, this is a 3-year plan. I think Tracy was very, eloquently said, when we talk about offenders, they are members of our local community, brothers, sisters, family members, etc. And sometimes we often forget that. And also, more importantly, often sometimes our victims as well. So for us, obviously, in terms of the cost of offending, it's really important that we work collectively and collaboratively in order to reduce that, and in terms of making sure that we deal with those needs that often help to reduce reoffending. The plan itself is broken down, you can see, into 5 key areas, which are around training, skills and work, drugs and alcohol addiction, family accommodation, readjustment to society, and public security through engagement and compliance. Just in terms of some headlines here that you can see, obviously there's a population across Kent, Surrey and Sussex, which is over 4 million. In terms of our probation caseload, it is about 14,000 when we first done that. I think that is now rising, and it's just under 16,000. And you will see there the breakdown in terms of the reoffending rates as per the probation delivery units that I have across Kent, Surrey and Sussex. And I know you'll immediately be looking towards Kent there with the 19.7%. And obviously, whilst looking at that average, we're going to be really keen to focus on these key areas so that we can look to reduce that rate going forward. Just to note that that was the published reconviction data dated back to 2019 to 2020. So obviously there's a slight lag in terms of that. You'll appreciate, particularly in Kent, but across Kent, Surrey, Sussex, there are a high number of prisons and courts that we have. I think we have some of the highest nationally within the probation service. So there are 11 prisons, 1 privately owned, and we also have a high number of courts as well. So the work that I do with the prison group directors is also really important in this area, particularly that transition between coming out of prison and how we manage those in the community. So just in terms of the highlights, as I said, just to break down, obviously training, skills and work, very important in terms of getting our offenders into employment upon release as well. So we also do a lot of work in terms of with DWP, but more importantly, there is a lot of focus now that we're doing around literacy and numeracy. I think none of you around here will be surprised that there are a number of adults that we deal with that still have problems with reading and writing, and obviously that does impact on us being able to get people into work and employment. So obviously we need to make sure that they can gain those practical skills, and obviously we work, as I've said, between that seamlessly between prisons and the community. So a number of offenders may be released from temporary release from prison so that they can undertake some employment to help them resettle. And obviously one of the key things for us is around vocation and skills and qualifications to make them better equipped to readjust into society. One of the other important things that's part of our plan is around community payback. You may well have seen some of the placements out and people wearing the high-vis vests. We absolutely work with a number of placements, both Kent, Surrey and Sussex. I think I was one in Gravesend the other week. We work with either day centres, we work with churches, graveyards, beaches, litter picking, you name it, we will deal with it. And obviously, again, if there is anything that the board has or is interested in terms of placements, do let us know. I think it's important in terms of the community being able to see some kind of reparation back into the community in terms of that health and well-being, particularly if you have a number of graffiti and things like that. It's really important to see people go out and to clear that up as well, and obviously important for the victims as well in terms of from that punitive angle. But linking into the Reducing Reoffending Plan, quite clearly it's also something where we can help and give people skills to help them get into employment as well. Family accommodation and obviously the readjustment into society is a big thing for us as part of the Reducing Reoffending Plan. Obviously, one of the key things, and I think obviously you'll all be more than familiar here, is around the issue around accommodation. That isn't just about those of our offenders, but also even for members of the local community. It's very difficult in terms of that. So for us, there is that extra challenge in terms of how we get some of our offenders into suitable accommodation and how that's managed. I'm more than aware that sometimes, you know, and councillors will probably come back, you know, the impact of why is it that offenders get housed first when we've got members of the community. But actually, as it comes back to the point that I was saying earlier about actually these are sometimes family members as well. And we have to ensure that we know where certain individuals are living. And actually, it's a very important part of that readjustment into society as well. So for us, we also have a project, a community accommodation service, of which we have nearly 1.2 million invested across Kent, Surrey, Sussex, where we work with providers to try and ensure that those individuals that are released from custody have an initial 84 days. And then obviously we work very closely with local authorities and housing departments in order to ensure that we have future accommodation and permanent accommodation going forward. I think one of the things for us as well around this is we're really, HMIP commented very much around the work we're doing with some of our women offenders and the breakfast clubs that we have, a really safe space, because it's really important that we have safe spaces away from some of the offices as well for women to be able to come, whereby we link in with local Morrisons, etc. We're able to get kind of starter kits for those individuals coming out of custody. But equally, that might be a good opportunity for us to link in with health partners as well, because the women feel safe and actually be able to manage that. And often we do try to refer them into local kind of services, particularly around drugs and alcohol, which I will come on to later as well. And I think, you know, the big thing here is about how we also engage with partners as well, because linking into what Tracy has said, when we're looking around violence against women and girls, the issue around domestic abuse, we need to make sure that actually we work collectively and with families, whether they're both female or male, in terms of making sure that the family and the children and those safeguarding needs are clearly managed. And that's kind of quite high prevalence in our strategy. Next key thing, obviously, around public security engagement and compliance as well. Just a few key things here. Obviously, for us in the probation service, we have a number of accredited programs for those on offenders to help them to address their behaviours. That may be from those individuals with sex offender treatment programs, but also we do a number around domestic abuse programs as well. So it was interesting hearing from Tracy earlier around how we're going to work with perpetrators in terms of addressing that. And also, I think it's important to note that with some of those domestic abuse programs that we have, we also work with victim services as well, so that many who are together, we can work collectively as well in terms of to manage that as well, not just from a public protection point of view, but also to pick up those safeguarding issues and address behaviours as well. There are also some key things here for us as well. We work collaboratively with the police, local authorities, children's services for multi-agency public protection arrangements. That would be when we're working with our more high-risk and dangerous individuals as well. And I think there's a lot of good work that happens across Kent in relation to that. And I think that's really important when we're looking at the management of our highest risk cohort. But equally, when we think about security here, we have a number of tools that we can use as part of the probation service, such as electronic monitoring, or for those that are released from prison, we can have them on home detention curfews as well. So that individuals that come out on licence will have a number of licence conditions or exclusions, etc., as to where they can or cannot go, where they can live, what treatment they need to undertake. And I think electronic monitoring is really highly effective in terms of how we manage those and our more highest risk as well. And again, very important when we're thinking about the women and girls strategy and how we work collectively in terms of delivering that. Another key thing that may be of note for those of our in the health profession, we obviously have the offender personality disorder pathway as well. This is jointly commissioned between HMPPS and NHSE as well, and that's about providing psychologically informed services to those that are highly complex and those with personality disorders as well. Pleased to know that in Maidstone we have a very effective department that manages those individuals, and equally we also work in with those that have been released from prison as well to look at those psychologically informed services as well. You'll see there that there's a breakdown of how we manage those individuals there, and it's really important that we look at the identification, that we end up having some treatment and have clear pathway planning for them in order to manage that. And I know we're working quite effectively with mental health provision in terms of that. I think the next slide just highlights some of our intensive interventions really that we have, and obviously this is done in collaboration with NHS as well. And I think more so this model here that we use, which some of you from health background will recognise, this is the intensive treatment that we would use for those that have done long-term sentences or have come out on life licence as well. So I think it's really important to kind of note that, and I think at the moment we are trying to also look at how we expand those services, and we also have some money to help with any co-commissioning. So if there's anything, it'd be great to hear some any ideas as to how we can work collaboratively in relation to that, or also look to expand it. I think the big thing here today, in terms of the next slide, obviously one of the key things is around drugs and alcohol addiction as well. We write reports for the courts and make recommendations to the magistrates and the judges, and I think some of the things to help us with that kind of desistance and reducing reoffending is very much around alcohol treatment requirements and obviously drug requirement as well. I think it would be really good going forward for us to acknowledge how we can work closely with providers, because we are looking to see if we can increase the numbers of those on ATRs and DRRs as well. I think, you know, I've heard here this afternoon we've fully recognised the impact that COVID has had as well. There hasn't been some of that face-to-face, and I know that some of our sentences have certainly picked up during that period of time, but I'm really keen as part of our plan that we have to work collaboratively in terms of taking that forward. We're also looking at mental health treatment requirement orders as well. We're doing some work with St Andrews and the NHS, which has just started at Maidstone as well a couple of weeks ago. We're really keen in terms of looking to expand that into Medway going forward. So again, it would be something I'd like the board to note, because actually it would be really good for us to work in order to take that forward. Again, the numbers around mental health treatment requirements are very low. So for us, I think given that the population, particularly within West Kent, Medway, is like 4,500 offenders, I think there'd be certainly a higher proportion of those coming through that we need to make sure that we capture in terms of doing that. So for us, it really is about seeing how we can meet and work collaboratively to meet that demand, and also to identify those individuals as well. And obviously working with healthcare and substance misuse providers will be critical in terms of doing that. Again, you'll see here in terms of for us around the community sentence treatment requirements, at the moment, government are very keen that we drive that. It's a very high ministerial priority as well. And it was great to hear, you know, the work from the GPs. I recognise the challenges that there are in relation to that as well. But for us, I think we have to ensure that we do work in order to invest, and any new investment that we have that can help for me to take that forward within probation would be most welcome as well. And obviously for us to be included in any co-commissioning or new specs as we take that forward, and make sure that we're sharing that kind of segmentation data. So I think just a couple of things here in terms of how to seek some support for us from the probation service in terms of this plan. Obviously, I've already highlighted, obviously we've got the new commissioned rehabilitative services for dependency and recovery for those on probation. That goes live for us from the 12th of September, and that's going to be delivered by CGL. We anticipate, as you can see, about 2,000 people that will be going through that programme over the year, which would be great if we can maintain that or increase it. It's important for us to have a link in terms of any new commission services as well, because I'm very mindful in terms of the over the COVID period that actually we haven't done as many referrals as we need to. So I really want to make sure we have an open door there, and that actually we know what's available to support the reducing reoffending plan as well. I've spoken about the mental health treatment requirements and the fact that we have that in Maidstone as well. And again, I think, you know, it's important to note that issue around dual diagnosis, substance misuse, and how we manage that as well. And I think there's the issue around identification is still key for us to make sure that we're making those right recommendations to the court as well. You will see there from 2021, there was a low number of DRRs that we managed, which was 388. But actually, I'm pleased to report, and CMAC can give some few local stats, that we actually have more within Kent now. We have kind of 259. But based on the fact I was saying we've got 4,500 offenders, we know that actually substance misuse and alcohol is a huge driver, and certainly do want to make sure that we identify those individuals for that case. Just going to hand over to CMAC, but just to say that this plan is published on the government website as well, together with all the other 12 regional plans. And obviously, I'm more than happy to take some questions after CMAC's just given a flavour of what there is locally within Medway, but obviously recognising that you may have some questions shortly. CMAC.
Yeah, so in Medway alone we have 1,200 offenders. We have got a Medway office, which is our Chatham office. It has actually just had a refurbishment, and that was officially opened last week. So anyone that would like to come and visit is more than welcome to do so. Please do get in touch. Mary's absolutely right with the people on alcohol treatment requirements and DRRs. The numbers are lower than expected, but we are doing some local work with providers, looking to see how we can increase referral numbers, but also to build on the recommendations within the HMIP thematic on substance misuse and probation working closely together. And that's the usual things that have come up around information sharing, joint assessments taking place, access to training, awareness of what's on offer, but ultimately better outcomes for people that have alcohol and drug misuse issues that's linked to offending. So as I said, we've got 1,200 service users within the Medway office. We've got 7,000 in total across East and West Kent. Any more specific local questions, more than happy to take them as they come up.
That's great, CMAC. So obviously, great for you to, any ideas, suggestions, or how we can work collaboratively in terms of reducing reoffending would be most welcome. Thank you.
Thank you very much for a very informative presentation. Before I open the floor to members, James, you'd like to come in, please?
Thank you, Chair. Tracy, Mary, thank you, CMAC, for your presentation. I think it was helpful for the board to get the context of the broad brush and the depth of the work that you're doing, and clearly from our perspective, you've come with an ask, and clearly that's the remit of the board. I just want to make a couple of points. So I think the detail we can deal with, so I think we can take some of those conversations offline as to how we interface in general terms around some of those services, whether it's housing. Of course, hopefully you're aware, Mary, that local authorities are the ones that commission community drug services, so you'll be doing your inpatient stuff, but and we're going through a process at the moment around recommissioning and retendering for our drug and alcohol services, so that's a conversation that we can definitely pick up. But the main thread that I actually want just to come back to was the importance of the issue, particularly I go back to Tracy's point about the violence against women and girls. Again, I'm going to put Leanne on the spot, but as Director of People, one of the conversations that she always has with us is, what are we doing for our population? How do we actually support, and you mentioned women and girls, they're at the bedrock, unfortunately, of some of the issues that lead to then families breaking up, the impact that that has on the lives of not just those people that are directly affected, but everyone else that falls into that chain. And you only have to look at the news as I did last night, and I was disgusted, if I can say this, for the issues up in Chorley. I mean, you see that type of stuff, young girls being brutalised, unfortunately, by other young girls from what I could see. So there is a huge agenda there, I would suggest, around the well-being of and safeguarding of those young people. But actually, the health bits that you fleshed out, the substance misuse, we've already had a debate, you heard that about the primary care, about access. Some of those young people, how do they actually access some of these services? What are the needs? You know, folk coming out of prison under care and support, we know that their health, and particularly their mental health, is often a challenge. So, huge debate. I think the board have got a lot to offer. I think some of the detail, though, as to what you've asked for, we can definitely, because a lot of those sit directly within my gift, to be fair, in terms of some of the asks. But clearly, I think we've got Martin here who deals with a lot of the community services. Clearly, Becca here from the ICB perspective. I'm pretty sure that we can pick up some of those pathway discussions because we've now got the structures. And one of the things that I was just noting down was our integrated care strategy that's in development. We'll have that fleshed out by the end of December. You may well want to make a note that it's been informed by the joint strategic needs assessment, of course, our joint health wellbeing strategies. Your population, because they are our residents clearly when they come and live with us, but those people, particularly the custodians that are in the, whether they're in a prison in Kent or in Medway, it'd be helpful to get the Medway data on the breakdown. I'm sure Simi could give us that in terms of your rehab stats. But they will form part of our work that we then identify, because we will work with NHS England and the Health and Justice team to give us some of the information that we might well need to develop our integrated care strategy. I just want to frame that out, and it may well just be helpful to pick up an offline discussion. Sue sat next year, for example, Tracy can pick up your ED stuff, as can our chief exec over there in terms of the Medway impact, but you've also got lots of other hospitals around the place that you would want to engage and liaise with. So I just want to do that very briefly, Chair, because that might just help to move the conversation on briefly for Mike.
Yeah, you'd like to come back on that, Tracy?
Yeah, no, just thank you very much, and I'd love to take that conversation offline. I'm sure Mary would, or Sumac would as well. The other thing I think is you talk about the joint strategic needs assessment, really important. Our chief analyst, I think, has taken the lead across the partnership to try and look at the partnership data aspect, because we have got really good service from Medway, to be fair. We really struggle with some of the other places around health data, and it's been a requirement of the government under VRU for 3 years now and still not unpicked it. So that would be really good as well, because I think that we've seen examples in Wales where we've targeted things with the police data. When you overlay it with other people's data, we're completely in the wrong place. And it really helped with reducing knife crime, for example. So Nicola's working really hard. And I think, to be fair, Medway have been really good around it, just some others.
Okay, it's on now. Yes, so we are just starting to work with the Violence Reduction Unit, and we're going to be having an analyst in our team, in our public health team, who will be working on the Violence Reduction Unit data, applying public health approaches to that data. So there should be some opportunities there to work together.
Any member, please. Vince.
Thank you. I'll be brief because I'm very conscious of time. And thank you both collectively for your presentations. I guess one, and James is right, actually, the granular detail is not for today. That's for conversations with people who know far more than I. And those will be helpful, and those will ultimately lead to better outcomes for those in both parts of the system. I think that's important to recognise, and it is actually helpful that we heard both those presentations together. I just want to pick up one issue for both, so you don't feel left out. And Adrian's heard me and colleagues say this repeatedly over the last year in particular. We know, speaking to women and girls in Medway, that the concerns are real, the concerns are genuine, and they continue to be. One of the things, and I say this as someone who did an hour-long chat on Radio 5 a few weeks ago on this particular point, and that's around, actually, if we think back to those tragedies like Sarah Everard and the others we've seen in the last 18 months and long before that, the instant reaction is always, what can women and girls do differently to make themselves safer? And that's the wrong statement. The statement should be, how on earth do we stop men doing stupid and criminal and illegal and immoral things? And there isn't a simple sentence to how to do that. But I think we're slowly turning that corner, that actually the response... But we did see a bit of this, didn't we? Post Everard, we regrettably saw, look, here's an app, so you can be... Someone will know where you're walking. People shouldn't have to have that app. So I just want to get a sense of feeling as part of that strategy and ongoing work, and we have the White Ribbon campaign, and that's the important tool, but it's not the only tool. How do we collectively as a system So not just the police, not just the council, but actually society as a whole here in Medway. How do we make sure that we're saying to men and boys, this is deplorable, unacceptable, and all the rest of it? You may not have all those answers, but this is important to say, actually, that's where we need to get to. And for probation, I mean, I think the MHRT stuff sounds really interesting. My concern, you know, I've spoken to a number of residents who have been in and out of the criminal justice system, clearly have some underlying, by their own acceptance and recognition, have those mental health challenges, often, but not always, linked to the toxic trio, as you say. But actually, it's around capacity. So if we say we're going to start this new thing, and you start those conversations, my concern is within a few weeks, actually the backlog there will look like the backlog for lots of other things which are trying to tackle mental health challenges, which are, you need to see someone, but the waiting list to see someone is X weeks or X months. And just how do we collectively make sure that if there is a new pathway, a new conversation, that we're not setting up people for a bit of hope to then go, actually, yeah, we'll see you next year. Thank you.
Thank you, Vince. Maggie, please.
Thank you, Chair. Thank you both for very informative reports. My question is for probation, though. So my background is substance misuse. I worked in the Shebby cluster for 15 years and also in the community, both in Kent and Medway. ATRs and DRRs are fabulous. The problem comes when the individual isn't compliant and we report it and there's no action taken. So it feels a little bit like a toothless tiger. So I just wanted to know how you were addressing that.
Could I perhaps ask that if you can come back on Maggie's point, and then I was very conscious, only after I'd said thank you, Vince, and moved on to Maggie, that I hadn't given you the opportunity of coming back on Vince's part. So I'll leave it to you, please. Maggie's first, and then back to Vince's points.
So it's working now. Just to come back on your point about, so from probation's point of view, I think you make some really valid points about how do we make women and girls feel safe as well, and a bit around the family. I do just want to reiterate, which probably didn't come out in the presentation, obviously for us, anybody who does come out who has committed any high risk offences, we have a multitude of licence conditions that we can give individuals. So we also have our victim service as well. So we would be working with any individuals in relation to that to ensure that those that need those specific licence conditions, electronic monitoring or anything like that, we manage that, and we work collaboratively with the police with our multi-agency public protection panels or via MARAC as well to make sure that we are absolutely managing those cases as well. I know there's a bigger issue there, but for those that are coming out, I did just kind of want to reassure of that, and I'm sure Tracy might come back on the other points. In terms of the bit around the ATRs and DIRs, I'm absolutely crystal clear that if somebody is not complying, they will be, those orders will be enforced and they will go back to court. I'm sorry to hear about your experience, I generally am, but one of the things that we absolutely can't have, and you know, it's proved in the evidence and serious further offences, that actually if somebody is not complying with it, that is an issue and a risk, and it's an escalation. So, and CMAC is here as well, I'm very hot on enforcement, or those that breach their licence conditions as well. And if there's anybody around the table who's hearing different, then please do come to me. But enforcement is critical for us in terms of managing that, as well as rehabilitation.
Thank you, and thanks, Chair. I mean, I absolutely agree with you. This isn't about women changing their behaviour. It's about how men, young boys, and other women who are offending against women stop. So hence the offender-centric sort of approach. For too long, I think people have been made to feel like sometimes it's your fault for going out late at night, blah, 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 and it's absolutely not. So we've got a really good opportunity around education. We've got quite an investment in Kent Police around schools officers, and the schools are really engaging. So we've got a real opportunity there. We know that an awful lot of this moves online, and actually in term time. You'd think it would be holidays, but it's actually not. Our analysts have shown us it happens in term time more online. So that shift and the platforms they use, there's a whole raft of offences, as you know, coming out, which we do need to do a big awareness around But it's about stopping it in the first place. So some of the preventative orders that the government are giving us as tools are very, very powerful, and hence some of the conditions that we need to put on may be linked to some of the triggers for their offending. So we have got lots of tools in the box, either with us already or coming, and we're absolutely keen that we will use those because it is about preventing it in the first place so people can walk around feeling safe. That's what ultimately they need to be able to do in their community. Just, sorry, Chair, just an invite. Next Friday, Medway are the first district that we're going live with our walk and talks with women in the community as well. So if anyone would like to join us on that, just to get a real sense from local women, areas they're walking through at different times where they're not feeling safe, we can look at that environmental issue as well.
Thank you very much. We'll make sure that that information is passed around, but thank you for that. Adrian, please.
Yes, and thank you for the very interesting presentation, particularly so as I chair Medway's Community Safety Partnership. And I'd like to assure you that we are doing a lot of work on the ground. Tracy, I don't know if have you had a chance to meet up with Sharon Adley and seen some of the work that the Medway Task Force has been doing?
I'm aware of the task force. I haven't met with Sharon yet, but I'm meeting the chief execs next Tuesday, and then I'm assuming I can come out and maybe meet some of the... Is she a community safety manager?
It'd be really good if you could, because Sharon's been absolutely brilliant in levering in safer streets funding. We've had two quite large tranches now in Medway, which has been used to do lots of practical things on the ground. We've worked with local retailers and other outlets to provide safe spaces in Medway for women to go to. We've been engaging people in active bystander training to try and deal with the issue that Vince says of getting men not to, when they see this behaviour going on, that they will actually be prepared to intervene and say it's not acceptable. We've even run drop-in sessions for sex workers because they are very, very vulnerable members of our community. And yes, we do distribute the Holly app because we don't yet live in an ideal world. Yeah, it'd be great to be in a position where we don't have to do that, but we have got the Holly app available. So there is a lot of things going on there. But I'm also pleased on the probation side. The probation service here locally work very, very closely with our community safety partnership. We have somebody representing them at every time we meet. In fact, at our last meeting, we had the IOM report from the Kent and Medway Reducing Offending Board, which that regularly comes to us. So, there is a lot of very, very close working. We use community payback. Also, it didn't mention actually, when it comes to drug and offender sort of rehabilitation. Here in Rochester Prison, there's a lot of work being done by the Forward Trust. I think it's in A Block to try, to encourage people to come off drugs. And there's some really brilliant work doing that. And again, with the Forward Trust, our facilities management side, Medway North, have been very good at taking on ex-offenders. And in fact, that's been recognised by the Forward Trust. And a little while back, I was able to go to a presentation in the House of Lords on that subject. So, there are a lot of things going here on Medway. Also on domestic abuse side, at our last community safety partnership, we had a very good report on that, and very impressively how Kent Police are actually using mobile communication things to actually interview the victims of domestic abuse. In fact, I think there was a very good lesson for the health service from that, of how efficient that has been. And people say having remote sessions with the doctor's not the real thing, but certainly from that report, the work that was done by Kent Police has actually dramatically improved the DA service. So there are lots of things going in Medway. Tracy, it'd be really great if you could come and visit the task force. I'm sure Sharon would love to tell you in much, much greater detail than I've been able to in the last few minutes, but I can assure you that we do take these issues extremely seriously. Whilst it was a bit disappointing, we had at our last community safety annual survey, the question on where people rated violence against women and girls came extremely low in people's views. And it's surprising that, because we had over 700 respondents, the majority of which, by quite a margin, were female, and yet they didn't see that as an issue. Whether that's a good thing or bad, I don't know, but I can assure you that we do take it seriously as a community safety partnership. And you know, certainly, if you'd like to come and talk to our community safety partnership as well, we would love to have you along. Thank you.
Any other member? Yeah. Over to you, please, Vice Chairman.
A pleasure to move that the board note the presentation and thank both the Assistant Chief Constable and Mary Pilgrim for their answering the questions and also giving us a very good insight into how the probation service in particular is working.
We agree. Thank you very much, and thank you again for blessing us with your presence this afternoon. It's been very interesting. Thank you. Right. Item 10, the emergency assistance to Ukrainian refugees, report to be found on pages 223 to 228. And we have Mark Brithwick with us this evening, the head of housing, who will introduce this item. And thank you for your patience, Mark. The agenda's been up and down, round and about, but thank you.
Thank you, Chair. So I'll take the report largely as read. I just want to make two very quick points about things that aren't covered in the report. So one is that this scheme is very different from other refugee schemes in that it's predicated on the issuing of a visa and a named sponsor in the UK that will be, for the Homes for Ukraine scheme, will be typically will be unknown to the Ukrainian guest, and under the other scheme it will be a family member, so they'll be issued a visa under the family scheme. The second point I wanted to make was just to convey my thanks to officers and departments within the council, the voluntary sector, and other organisations that have supported this work to date. But from there, I'm happy to take questions.
Any member, please? Howard and then Vince, please.
Can I just make, first of all, can I congratulate Mark? I've obviously been very much conscious of the work he's been doing on this issue. And I think it's very difficult because we suddenly sort of get a whole lot of names to us and we've got to check them out at speed. And I think we're being very thorough in the way in which we're checking not only the fact that the hosts are suitable in the terms of their premises and obviously they haven't got any convictions or anything else that might impinge on the situation, but also I think the fact that we then call afterwards to make sure the arrangement is working properly. I think the fly in the ointment actually will be at the end of that first 6 months, because it either happens in the first 2 weeks or it happens at the end of 6 months, because most people may well have moved on by then. I know that quite a lot of them hope they'll be moving back to a peaceful Ukraine. I don't think that's going to happen. I think that many of them will stay here. Many of them, of course, have left their husbands behind and will never see them again, which is even sadder. So I think that the fact that we are providing these services, I think, is pretty good, really, in the sense that it makes me very proud of Medway that we are doing our bit for this, and without Mark, we couldn't do it. I think that there's put a lot of strain on people to actually deal with this situation, but I think the reward is in the fact that people, after all those years of uncertainty and then a major war, which I think they long anticipated, and now, despite the fact some of them don't know whether their families are alive or not, but they've been sent on a train away from Ukraine, so totally into a country they don't understand, that runs on different rules, the education system runs on a different basis, and so on. And I think that in tackling those issues, I think that we've tried to hold their hand in a sense so that they do begin to find a home over here, and I suspect they'll actually enrich the population quite considerably, because many of them are not by any means short of skills.
Thank you, Howard. Vince Maple, please. Vince.
Thank you very much, and I'd echo a lot of what Howard has said there. I've got a huge thank you to Mark and the team working around him and the wider team, as well as a thank you to those who, in genuine record-breaking time, have formed Medway Help for Ukraine as a fully formed charity. I have never known that process happen so quickly, and that's a tribute to everyone involved. And I'd also want to thank, of course, all the sponsor families. Nobody is forced to do this. The fact they've stepped up and done it just shows, once again, how compassionate the people of Medway are, and we should be rightly proud of that. I just want to pick on two very details, though. So on 3.9, obviously I appreciate some time has moved. My Facebook told me today some schools started going back because I saw lots of small people in uniforms. So I just want to get a sense of feeling as to whether those last 5 children have now received an educational placement, because that has all sorts of health and well-being impacts if they haven't as yet. You may not have that information to hand, I appreciate, but if you have, that would be helpful. And then just picking up on Howard's point and just expanding that slightly, is there scope, as far as you're aware from conversations with others who are doing a similar role in other, certainly upper tier authorities, could this scheme be extended to run beyond a year if there was political will? Or are we in a situation where it's got to end at a year, because sometimes legislation does that? I agree with Howard. I think, regrettably, the circumstances will be that people who desperately wanted to go back as soon as possible may not be in a position to do so safely for a period of time yet. And of course, I recognise that the challenging situation for your day job, Mark, and the excellent job you do there, of course, is that paragraph 3.19 and 3.20 around actually if the relationship is coming to a natural end. If people had young people at university and now they're back at home, that means that the spare room's no longer spare. So I guess this is, of course, something that we will have a watching brief on, but it's around whether we have the ability locally or whether nationally the legislation will allow for that to run past a year if it's needed. Thank you.
Of the allowances, isn't it? What we obviously will do, and I think what the government will do, regardless of what complexion it may be, they will look at these and say, is there still a problem here? Do they still need support? I'm honestly quite optimistic about this. I think a number of the Ukrainian people will actually come over here, will actually settle down as a sort of, I mean, there was one case, I know that there's one, she's actually gone back, but she said she was treated as a daughter, an extra daughter of the family and so on. And I think this is not an isolated instance. I think that I think they do provide a good quality of life here. They enjoy being here, but obviously it is going to be, there are going to be a lot of people, I think, at the end of that 6 months that will want to stay on, and they've got 3 options, really. They can either go back to Ukraine, which many of them won't be able or can't do, and I would like to hope the government will help them if they do have to go back. They can continue with the hosts if the hosts don't mind, but the question there is, of course, if they're not getting any help with the costs of that, they may or may not be able to continue that. But of course, by that time, you hope that the person concerned has got a job, if they can get one. And then, of course, there is the case really where they fall through the net. They're going to be homeless and so on, and we will pick that up. and make sure that they are appropriately housed. And we've got an officer that's dedicated to that, this whole process. So we are watching every single one of these placements for any sign of an adverse effect. And both the Ukrainian person or persons and the hosts know they can come back to the council and talk to us about any problems that are arising. So I think that's probably the answer to your question.
I think it was just to follow up on that point about schools, Councillor Maple. So that up until the summer break, as it were, there weren't any children that were missing, that weren't in a placement. So, and our admissions team have been really great at making sure that happens in a very timely way. So I will certainly confirm, but I would imagine very quickly as the schools return, those 5 children without places will be found places.
Any other member, please? Well, before I hand back to the Vice Chairman, I equally would like to express my thanks to Mark and the team for the hard work they have put in. There's no doubt about it, the people of Ukraine have certainly come to the fore, and in coming to Medway, I've seen so many examples of help, support, and a very warm welcome being extended to people. And this has been very spontaneous by the people of Medway. It's been quite heartfelt, I'm sure. But thank you, Mark. And now I pass back to the Vice Chairman, please.
Yes, can I move the recommendation in section 6 that the board note the contents of the report?
Right. We're getting close to the end of the agenda items now. Item 11, please, the Better Care Fund, pages 229 to 250. Sue Irving, the Head of Adults 25 Plus Partnership Commissioning and Better Care Fund, will be introducing this item. Sue, over to you, please.
Thank you, Chair. I'll keep this very brief as the evening wanes on. I'm here to support the paper asking the Health and Wellbeing Board to support the BCF plan for 22-23 that has been submitted to Regional Assurance, and whilst we were sitting here I got very positive feedback from it. This will then go to Cabinet if supported by the Board and then submitted nationally at the end of September. I'll take questions.
Thank you, Sue. Any member, please?
Say so, Chair. I don't think there's a lack of interest in the Better Care Fund. I think actually it seems to be working very well, and I think that all those engaged in it, is a really good example of how we can cooperate together as a sector. And I think I think that says volumes to the people involved. So please don't think we're not interested in this. We are very interested in it, and I think you've done a very good job.
Thank you very much, Howard. That is actually right, Sue. We would like to know more if there is anything else that you would like to share with us, but I think all the points that we would like to know have in fact been covered. But I suppose there is one question that perhaps is always pressing, and that is that do we always get what we need from the Better Care Fund, or are we sometimes left holding the baby or an elderly person sometimes, perhaps?
Well, to answer your question and Councillor Doe's comment, JCMG manage the money very, very well. There are very strong conversations to make sure that the money is spent well and properly, making sure it's person-centred and appropriate. So, if my assurance is anything, I admire them from being part of watching them work to see how hard they work for Medway's residents.
Over to you, Vice Chairman, please.
Would the board please note the plan for 22-23 set out in Appendix 1 to the report, and agree that the draft 2-year plan for 2023 to 2025 be brought to the board in the autumn of this year.
Are we agreed? Okay, thank you. Final item on our agenda is the work programme, and page 309 to 314. And here I'll pass over to Jade Hannah, Democratic Services Officer for Medway Council, who will introduce this item, please.
Thanks, Chairman. So as is report as read, just to say that obviously earlier in the discussion, I've undertaken to liaise with our colleagues in health to schedule a progress update on the General Practice Development Plan, and we'll talk about that at the next pre-agenda meeting.
Any member of Vince, please?
Thank you, and thanks, Jade, for the report, and welcome back. Obviously, we were all talking about it there, but it would seem strange to take the GP task group report and not an update report at the same time. So I would be anticipating that to happen. The other thing I would suggest, again, to perhaps take and contact all colleagues, some of whom are not here today, I recognise. It's been a while since we've sense-checked when we do these meetings. Some of the membership has changed, and we have changed it in the past. We changed it to which day of the week, and also a slightly earlier start time. So I wonder whether there's a quick sense check just to say, is 3 o'clock on a Thursday good, or is there a preferred alternative? And perhaps that can come back in the next work programme item in November.
Okay. I think perhaps on that particular item, Vince, it would be useful if we could send around and get a feel from members of the board as to how they feel. I know when we first started, we did our best to accommodate the GPs, the medical people, and indeed the hospital to fit in with their hours of business, if I can put it like that. But over the time, we have changed. We've moved things around. So yes, I think it's always good to revisit that. So yeah, let's. Can you canvass members, please, Jade? Any other member, please? Okay. That really does bring us to the end of the meeting this afternoon. And oh, sorry, the recommendation. Sorry, I'll pass to you.
Well, the recommendation we accept, just the board accepts the work programme which the applicant one, subject to the comments that James has made.
Right. Are we agreed? Thank you very much. Right. As I started to say before, Jade tapped me on the arm, and that is to say thank you to all of you this afternoon for your attendance. There's only just one last item that I'd just like to raise, please, and that is that halfway through the meeting, I welcomed Jade back from maternity leave and said how pleased we were to see her. And in fact, her efficiency is such that she wouldn't let me get away with even making sure that the recommendation for the work programme, which comes under her remit, was done properly, hence the tapping and tugging on my arm. But the reason I'm mentioning this is that Jade, having returned to Medway Council and indeed to the Health and Wellbeing Board, I was greeted with the news early last week that Jade, while she loves us so dearly and missed us while she was on maternity leave, I think she's had a feel for what's outside of the remit of Medway Council. So Jade has decided that it really is time to move on to pastures new. And I'm very sad. It was nice to see Jade coming back, but here I am once again saying, Jade, thank you very much for all the service that you've given us here on the Health and Wellbeing Board, and in particular the help and support that you've given me under the brief, how can I say, support of Debbie, who was extremely good. It was nice to see you back, Jade, and now we have to say farewell again. So we wish you well, Jade, we really do, and thanks again for all your help.
Thank you.
Take care.